Pero a mí los números me dicen poco, y yo creo que los médicos, los neumólogos y cada vez más también los oncólogos estamos acostumbrados a ver casos e imágenes, y yo creo que lo que quiero representar con este esquema que he hecho a propósito a esta charla es la gran variedad de posibilidades de presentación que tienen estos pacientes. Hablamos de pacientes que presentan desde 2 o 3 nódulos en un mismo lóbulo y un ganglio o una sospecha o una adenopatía a nivel del ilio, hasta pacientes que presentan grandes masas centrales con invasión de estructuras vitales claves como grandes vasos o esqueleto axial o otros órganos, ¿no? Entonces hablamos de un estadio enormemente heterogéneo, que es como empieza cualquier revisión del estadio 3. Un estadio enormemente heterogéneo donde hablamos a veces de enfermedad microscópica y otras veces de enfermedad bulky, ampliamente diseminada, extendida, está expandido por el mediastino, por ejemplo, ¿no? Y de enfermedad resecable, enfermedad potencialmente resecable, pero también, aunque en esta revisión de un consenso oncológico muy reciente asiático, el apartado de irresecable no incluye el estadio 3, a veces son también irresecables. Una invasión de un cuerpo vertebral, cadena, grandes vasos, es totalmente irresecable. Y luego, una cosa es que sea resecable, y hablamos de pacientes muchas veces, tenemos que también incluir en todo este denominador la operabilidad. Lo que es resecable en un paciente puede ser inoperable, y es un elemento que debemos de tener en cuenta cara a los nuevos tratamientos y las posibilidades que nos ofrecen, y a mí eso me parece clave. Esto abre a que en este escenario heterogéneo tengamos que participar tanto en la parte de diagnóstico, estadificación, pero luego en las decisiones terapéuticas muchos profesionales, porque las posibilidades terapéuticas van a variar, y radioterapeutas, oncólogos radioterápicos, cirujanos torácicos, a veces los neumólogos porque requieren patología, obstrucción de vía aérea principal, alguna otra técnica endoscópica resectiva, pero sobre todo los oncólogos tienen que trabajar y decidir de forma conjunta en esto lo de que es el abordaje multidisciplinar, muy adecuado el título del curso, como siempre en todas las ediciones, y en este caso hablando del estadio 3 más, ¿no? Y además a los neumólogos, que esto nos suena un poquito a ciencia ficción, y hasta ahí, ¿no? Y Mariano nos lo resumía perfectamente en este resumen fantástico de hace unas semanas publicado, donde nos contaba a los que no estamos tan metidos como ustedes, que participan en los ensayos y conocen de primera mano qué es lo que viene, pues nos resumía perfectamente qué es lo que vamos a tener en los próximos años, y la apertura de la esperanza que nos abre a los que vimos siempre este estadio con bastante escepticismo y nihilismo de cómo iba. Lo primero que decir, hablando de estadificación del estadio 3A, es que la estadificación clínica y la estadificación patológica no se llevan bien en el estadio 3, fundamentalmente en el 3A, y es donde más diferencias encontramos. No se crean que hay mucha literatura al respecto, hay pocos trabajos. Piensen además que tienen el sesgo de que no todos los pacientes se intervienen, solo el 15% de estas series, que son de miles de pacientes, se intervienen, pero la agreement, la concordancia entre el diagnóstico clínico y el diagnóstico patológico no es buena. No es buena en general en muchos casos de pacientes con cáncer de pulmón, pero especialmente en el estadio 3. Y esto es algo que hay que tener muy en cuenta, porque hasta ahora les ofrecíamos más o menos lo mismo a todos. A algunos se les podía intervenir porque eran diagnósticos postquirúrgicos, muchos de ellos, y a otros les ofrecíamos quimio, radio, la combinación de ambos, cuando se podía, en el escenario mejor, cuando coincidía que el oncólogo le podía ver y a la vez el oncólogo radioterápico, que no siempre, como ustedes saben, ocurre. En este momento que tenemos otras posibilidades, tanto para el tratamiento posterior, después del diagnóstico, como parece que va a venir para el tratamiento previo a un tratamiento quirúrgico o radioterápico, creo que el escenario cambia y hay que ser mucho más exquisitos en nuestro trabajo, y hablo un poco dirigido a la parte que nos toca a los neumólogos en esto. El diagnóstico y estadificación del cáncer de pulmón ocurre en una serie de procesos seriados donde entran múltiples profesionales, múltiples unidades, pruebas de imagen, diagnóstico clínico, etc. Y esto hace que haya una complejidad, sobre todo para la atención en tiempo y en forma, digámoslo claro. Es un estadio donde es especialmente importante hacerlo rápido y hacerlo bien. Esto puede sonar a perogrullo, porque hoy estamos hablando del estadio 3, pero esto es especialmente un cáncer localmente avanzado. Menos importante un paciente, yo creo, quizá con una enfermedad ya diseminada de inicio, con una enfermedad metastásica, un performance estado muy malo, o en un enfermo en un estadio 1 con un nódulo pulmonar de 1 centímetro. Y nunca más, nunca más ha estado más vigente un decálogo, unos 10 mandamientos que yo le titulaba en una comunicación personal que hice, Mariano, en el 4º curso de Avances del Abordaje Multidisciplinar. Éramos jóvenes de aquella, hace 5 años, parece una eternidad. Yo proponía de forma un poco ilustrativa nada más, la posibilidad de los 10 mandamientos del diagnóstico y estadificación del cáncer de pulmón, la posibilidad de andar en estos. Y la charla, los 20 minutos, 15 minutos que tengo, se va a centrar en demostrarles que estos 10 mandamientos no es que estén vigentes, es que en el estadio 3 son verdaderamente obligados. Primero hay que tener profesionales bien identificados, especializados y motivados. Y no solo neumólogos, hay que tener profesionales, como les mostraba, de múltiples servicios. Y el oncólogo, que hasta hace muy poco, en esta parte inicial de diagnóstico y estadificación, estaba fuera y ayudaba a la toma de decisiones cuando lo llevamos al comité, tiene que ser parte muy importante de esto, porque las posibilidades que ofrecemos van a ser diferentes en función de los esquemas terapéuticos o incluso los ensayos clínicos que esté participando el centro en el que trabajas. Un proceso y un itinerario consensuado y adaptado al centro. No todos los centros pueden tener probablemente lo mismo y hay que tenerlo adaptado. Gestión de casos, priorización de pacientes, historia clínica electrónica para trabajar multidisciplinarmente. Son 3 mandamientos que van casi de la mano y son juntos y van en este sentido. No vale igual introducir y hacer los mismos procesos diagnósticos y de inicio de tratamiento en un paciente con una lesión pulmonar de 10 milímetros, que es un hallazgo casual en un seguimiento, un TAC que se hace por una sospecha de embolia pulmonar, que un paciente que debuta con una hemoptisis y tiene una sospecha de síndrome de vena cava. No es lo mismo y no pueden ir y no puede ser un administrativo el que cita a estos enfermos de forma consecutiva. Tienen que estar priorizados y gestionados por profesionales. Y esto hay que tenerlo y lo tienen que tener en cuenta nuestros directivos cuando ordenamos y organizamos nuestras vías rápidas. Hay que conocer bien la rentabilidad de los procedimientos que hagas. Muy bien, tienes que saber tus valores predictivos, no solo positivos, sino también negativos, para ver con qué grado de incertidumbre vas a tomar decisiones diagnósticas. Un mínimo adecuado tecnológico nivel. Hoy, como veremos, sin PET, sin EBUS, diagnosticar y manejarte en el estadio 3 es jugar a los médicos. La investigación y la innovación y docencia, porque nos van a permitir los 2 anteriores conocer la rentabilidad de tus procedimientos. Si no investigas, si no lo analizas, no sabes lo que estás haciendo y jugarás y tocarás de oído siempre. Publicitar los días y logros para que tus compañeros sepan en todo momento dónde y cómo se tienen que ver a estos enfermos, porque no siempre los enfermos entran por una vía rápida de cáncer de pulmón, muchas veces entran en un servicio de medicina interna ingresados por otra cosa, en un paciente seguido por otra patología neoplásica lo ve el oncólogo. Tenemos que saber cómo funciona el hospital todo y cómo no, el último mandamiento y que engloba a todos, medir, medir, medir y corregir, si no los primeros 9 no tendrían utilidad. Estos mandamientos del cáncer de pulmón en el estadio 3 son obligados y me han facilitado mucho tenerlos aquí en la biblioteca que tengo de tal, volver a presentarlos porque perfectamente se adaptan al estadio 3. Esto de la gestión del cáncer, que hasta ahora nos dedicábamos unos cuantos frikis, yo creo que cuando Mariano quería hablar de esto, me llamó habitualmente, pero yo creo porque había poca gente que hablara de esto, y entre unos yo. Lo ha demostrado, se ha demostrado. Por fin hay un estudio serio, una auditoría grande de 33.000 pacientes que hace un score un poco basado o parecido a los mandamientos, en el que incluye también la presencia de un oncólogo dedicado a cáncer de pulmón, de un oncólogo radioterápico, enfermera gestora de casos, disponer de PET, disponer de algunas pruebas de operabilidad como el test de ejercicio, etc. Y con ese score de 11 puntos estratifica la población y ve los resultados, ¿no? Como ven en la columna de la derecha de la presentación, está en rojo aquellos puntos del score que cumplen menos del 50% de los centros, de los 129 centros auditados, muchos. En naranja o en ámbar, el los que cumplen menos del 70, muchos también, y solo 2 cumplen más del 70, 70 o más, que son la presencia de un radiólogo dedicado a un tercio de jornada a tal o de un oncólogo clínico. Los demás, como disponer de hoy el EBUS en un centro, a mí una prueba esencial, y si no hay que tener un circuito muy claro de derivación a otro centro para hacerlo, no lo cumplen ni el 70% de los centros auditados, y esto hay que tenerlo en cuenta cuando pensamos en el futuro de nuestros pacientes por cáncer. Fíjese lo importante de los resultados. Si uno cumple de ese score 0,4 puntos, se hace la referencia, es el 1 para el tratamiento en 2 meses, tratamiento con intento curativo y la supervivencia. Fíjese, si cumplen entre 5 y 7, el aumento tan importante de pacientes que han iniciado tratamiento en los 2 primeros meses, de pacientes con intento curativo y la supervivencia al año. 89, 1,89, un porcentaje altísimo. Pero si cumplen entre 8 y 11 puntos, y esto tenemos que presentárselo obligatoriamente a nuestros gerentes, es un estudio de referencia hoy en día en la gestión del cáncer, fíjense, en supervivencia al año multiplica la hazard ratio como lo miden en este estudio, de 2,30. Es altísimo en medicina. Esto es un dato para mí impactante y no tengo ninguna duda que el estadio 3 es de los que más se beneficia de cumplir este score. Lo primero es lo primero, ¿qué tenemos que hacer? ¿Cuáles son los problemas que tenemos los neumólogos? Y luego Gemma, como moderadora, probablemente podrá ahondar en alguno de ellos, porque seguro que sufre lo mismo que sufrimos los que iniciamos el diagnóstico inicialmente y la estadificación. Primero, el PET. Tenemos que tener acceso rápido al PET. Nosotros ahora tenemos la suerte de que ya el primer estudio en la mayoría de los pacientes es un TAC PET, con lo cual, con contraste, podemos evitarnos el paso intermedio del TAC con contraste. Esto aporta información. El estudio pivotal, el primero potente que se publicó, el de Fisher en New England, demostraba que en estadio 3A cambia claramente el porcentaje de pacientes, un 8%, y diagnosticas hasta un 14% más de estadios 4 con respecto a esto. Esto en el estadio 3 es esencial. Hoy en día no se puede hacer un manejo adecuado de este estadio, salvo enfermos que por otras comorbilidades tengan un estado de no hacer nada o de hacer poco y tratamiento únicamente paliativo sin PET-TAC, ¿no? Y es una prueba esencial y obligada. Lo segundo, que aún no se ponen las guías en los estadios 1 y 2, en el estadio 3, sin duda, en cualquier paciente con intento radical hay que hacer una resonancia cerebral, y es una prueba esencial. Si no puedes tener acceso a una resonancia cerebral rápida, te tendrás que arreglar con el TAC con contraste, pero de elección la resonancia cerebral. Y luego está el diagnóstico, la elección de la prueba. Y yo lo voy a hacer desde un punto de vista práctico. Miren la imagen del centro, es un TAC de un paciente de hace pocos días visto en nuestro hospital. Tiene una adenopatía 4R, grande, tan grande como la lesión nodular que tiene, en torno a 3 centímetros, no llega, un poquito menos, justo podríamos considerar 4R, aunque aquí está la ácigos, está ahí entre la 10R y la 4R, pero se veía desde cortes más altos, con lo cual parece una adenopatía o podríamos considerarla 4R. A priori, por imagen, parece un N2. ¿Qué prueba diagnóstica le hacemos? Aunque les sorprende, en muchos hospitales se haría primero una broncoscopia convencional, en otros sitios se haría una punción, en otros sitios, como el paciente a lo mejor está antiagregado, anticoagulado, tiene problemas, se le haría un cepillado primero, en otros sitios que no tienen EBUS le harían una punción ciega, pero yo no tengo ninguna duda, y en nuestro hospital es la que se ha elegido, que iría directamente a la ecobroncoscopia, porque me va a permitir lo que tenemos que hacer en estos enfermos, a la vez que diagnosticar, estadificar. Y si tienes la suerte de tener un patólogo en la sala, no solo te va a decir eso, sino te va a decir si el material que obtienes es suficiente y adecuado para hacer una buena caracterización molecular. Y el 3 en 1, en este caso, este lema es esencial en lo que hacemos. Diagnosticamos, estadificamos y obtenemos muestras moleculares. Para mí, hacer una segunda prueba para obtener un material insuficiente para un diagnóstico molecular, hoy en día es una frustración y un fracaso. Entonces, esto no ocurre siempre y creo que es clave también en estos estadios donde empezamos muchas veces por la estadificación o la aceptación mediastínica. Y hay pocas pruebas que han demostrado esto, y esto es la ecobroncoscopia. Un estudio británico en 2015 demuestra que los pacientes que empiezan cuando está acidicado, en todos los pacientes que entran a vía rápida, la ecobroncoscopia no solo disminuye el número de pruebas que hay que hacerle sin aumentar los costes, sino, aunque es verdad que es un estudio post-hoc, aumenta la supervivencia y se hace de forma más rápida. La ecobroncoscopia no es una evolución de la broncoscopia, es una revolución en la broncoscopia y en el diagnóstico y estadificación del cáncer de pulmón y en la caracterización molecular. En nuestra serie vemos aproximadamente unos 300 cánceres de pulmón al año nuevos, 600 sospechas, 300 se confirman. La prueba que mejor nos permite caracterizar molecularmente, hacer las pruebas, es sin duda el EBUS, porque es más frecuente que obtengas diagnóstico por EBUS que por biopsia bronquial, habiendo cambiado tanto la forma de presentación de los cánceres, con menos masas centrales y más lesiones periféricas. Esto nos permite que este paciente, ¿no?, y quiero hacerla muy práctica la sesión, ¿no?, como neumólogo clínico, que tiene una gran masa en el lóbulo superior derecho, una gran masa necrótica y una adenopatía subcarinal por imagen de torno a 15 milímetros, que bien la masa capta mucho y tiene sus zonas de necrosis y la adenopatía un poquito menos, pero su sub es de más de 2,5 en el PET. Haciéndole una ecobroncoscopia directamente podemos pinchar primero la adenopatía subcarinal, ver y hacer una estadificación contralateral reglada del mediastino, ver que esta prueba el patólogo nos diga que es negativa y directamente, sin introducir otro broncoscopio y a través de la tráquea, pinchar, como aquí les enseño, la masa que se ve perfectamente, se delimita, e incluso el paciente ha salido con un diagnóstico de presunción porque un patólogo en la sala te lo asegura, o por lo menos te dice que el material que ha obtenido es bueno. Lo segundo es saber si la prueba invade o no invade. Y esto no siempre es fácil, el TAC tiene limitaciones, ni el PET nos va a ayudar. Hay que recurrir a otras técnicas, a la experiencia, y por eso es muy importante que los radiólogos, el mandamiento 1, acuérdense, tienen que ser formados y preparados. No puede ser que la radiología torácica del cáncer de pulmón cada día la haga un radiólogo diferente, y menos en un centro de referencia. Y no siempre es fácil verlo. Y si no tienes seguridad con la radiología, porque cambia, un T2N1 es un estadio y un T3N1 es otro, y el tratamiento que le tienes que hacer es diferente, según las guías, tan diferente que puedes ofertarle un tratamiento, y va a ser así, como ustedes nos lo van a adelantar hoy, en los próximos años va a ser la pauta que parece que se va a imponer, ¿no?, los tratamientos previos con inmunoquimioterapia, o es muy probable que así ocurra, va a cambiar mucho y por lo tanto es clave que lo de T2-T3 que vemos muchas veces en los informes se evite, y para eso necesitaremos resonancia rápida, no vale una resonancia dentro de un mes, o seguridad por otras técnicas, y a veces incluso tendremos que llegar a hacer videotoracoscopias exploratorias porque cambia el manejo, y es una posibilidad que no descarto y que ya en algún caso muy determinado lo hemos hecho. En grandes invasiones mediastínicas, en otras más dudosas o invasión de vasos, a veces nos manejamos con probabilidades en torno al 80-90% en función de los hallazgos. Y para mí, y antes de hablar del mediastino me parece esencial, lo más difícil de todo es esta situación. Cada vez que veo más de un nódulo empiezo a temblar a la hora de decidir. No es fácil distinguir las lesiones en vidrio ilustrado que vemos tantas veces si son un proceso nervioso intercurrente, un proceso infeccioso intercurrente, perdón, si el bronquio está obstruido puede tener una neumonitis posobstructiva, si a la vez el paciente tuvo un sangrado o una clínica infecciosa reciente, si es residual o no. Y los criterios que nos definen, que nos ayudan a diferenciar si son tumores primarios múltiples, si son nódulos tumorales separados, adenocarcinoma de tipo neumónico o múltiples adenos con opacidades en vidrio ilustrado de crecimiento lipídico, no son fáciles de hacer en la práctica clínica. Y más cuando hablamos de pacientes a veces politratados, con otros procesos intercurrentes diagnosticados en el curso de infecciones. Es un verdadero problema. Y en este momento, que insisto, nos manejábamos en el manejo de dos técnicas, va a cambiar también y vamos a tener que afinar mucho más, y es un reto tremendo para los neumólogos, los radiólogos, donde el oncólogo nos tendrá que decir qué posibilidades tiene este enfermo si decimos que es una cosa o es otra, y porque pueden ser muy diferentes. Y por último, quería hablar un poco de la estadificación ganglionar, ¿no? Una cosa a la que me he dedicado tanto en aspectos no solo de práctica clínica, sino también en investigación. Como sabe Gemma, tengo que decir que una de las personas que me enseñó a hacer EBUS está ahí presente y es la moderadora de hoy, y de las primeras ecobroncoscopias que vi yo en mi vida las hice en el Hospital Puerta de Hierro. Y era la primera vez que visitaba el hospital, por cierto, Gemma. Bueno, decir que esto es un reto, y es cuando hablamos del estadio 3 pues todo el mundo piensa en los ganglios como un problema y un reto diagnóstico. Tenemos muchas técnicas radiológicas, semi-invasivas e invasivas, y todas tienen sus sensibilidades y especificidades, no les voy a referir. Han visto esta diapositiva probablemente cientos de veces. Ninguna es sensible ni específica de forma, específica sí, pero sensible, ni tiene un valor predictivo absoluto, ninguna. Puede haber alguna serie que lo tenga, pero no es la práctica, la norma en la práctica clínica. Ni todos los ganglios que vemos, y les enseñaba un ejemplo de un ganglio que yo mismo no sabía muy bien si era 4R o 10R, para mí 4R porque estaba claramente por encima de ácidos, aunque se extendía, no lo vemos y les voy a poner un ejemplo ahora. No todas las técnicas acceden a todos y hay trabajos, y esto no es práctica clínica, de gente que llega a la estación 5 o 6 pinchando a través con una técnica endoscópica y un vaso, pero eso no es la práctica clínica y tenemos que ver que la mayoría de los enfermos se ven en centros donde eso no se va a hacer. Les pongo un ejemplo. Este paciente tiene una masa en el lóbulo inferior izquierdo, que es un adenocarcinoma, tiene una adenopatía a nivel 4R, pretraqueal, aquí la ven, aquí está la vena cava, 4R, que capta en el PET 2,8, tiene una adenopatía en la estación 5, porque esto es el esófago, esto que tienen aquí es el esófago, y que con el propio ecobroncoscopio pudimos entrar a través de la vía aérea, pinchar esa adenopatía, el patólogo nos dijo que parecía ganglio normal, nos fuimos por el esófago porque por la vía aérea, por la tráquea sería imposible, claramente con el propio ecobroncoscopio y en el mismo acto diagnóstico confirmamos un N2 y se obtuvo material adecuado porque el otro diagnóstico había sido por PAF en otro centro y era insuficiente para una toma de muestras para caracterización molecular en una mujer, en un hombre no fumador. Cuando hablamos de estadificación mediastínica del cáncer de pulmón, tenemos que hablar de tres escenarios. Un escenario con probabilidad baja, lesión nodular periférica, estadio T1, T2, pero no central, pequeño, no nos preocupa, podemos realizar los procedimientos terapéuticos adecuados al paciente, pero ya empieza a haber otra situación. Cuando el tumor es más central, es más de 3 centímetros, o por imagen o confirmada tenemos un N1, la probabilidad que se nos escape una afectación ganglionar no vista puede llegar al 20%. Y luego, claramente, cuando tenemos diagnósticos, lesiones que por PET o TAC tienen más de 10 milímetros o captaciones significativas, pues hablamos de probabilidad de más del 20%. Esto que mucha gente ha intentado diferenciarlo y realizar técnicas diferentes ha supuesto o supone dificultades en la interpretación. Y yo que represento esto un poco como de broma, lo considero un tema muy serio. A mí me parece muy enriquecedor el debate entre cirujanos o las revisiones que hacen los cirujanos y las que hacemos los neumólogos, si hay que confirmar todos los resultados negativos, si había que hacerle mediastinoscopia al segundo escenario de los que le presentaba antes, si no, cada uno tira para su ascua. Y yo creo que hay que llevarlo todo a una complejidad mayor, no se puede simplificar, cada paciente es un mundo y eso es lo que quería comentarles. Las guías tampoco te ayudan mucho porque son un poco diferentes. La guía, la guía publicada en CHES, americana, nos dice que hay que empezar por técnicas no invasivas, no semi-invasivas, EUS/EUS, y que en el caso de que fueran negativos habrá que individualizar y tomar la decisión de si confirmarlas quirúrgicamente. Las guías quirúrgicas claramente se pronuncian que hay que hacer una estadificación invasiva y que incluso dicen que EBUS-EUS o mediastinoscopia. Yo creo que esto hay que matizarlo. Otras guías son más incluso difíciles de interpretar y dejan lugar al sentido. En este sentido, por ejemplo, una representación, una revisión, excelente revisión, por cierto, quirúrgica, que sigue las guías quirúrgicas. En los pacientes con un tumor central, aunque el mediastino no haya nada, recomiendan una estadificación mediastínica con EBUS-EUS o mediastinoscopia. Yo creo que esto, hoy el EBUS y EUS ha superado claramente como técnica de elección en la mediastinoscopia. Otra cosa es que tus resultados no sean buenos y por eso hay que irse a otro de los mandamientos. Medir para corregir. En cambio, en los pacientes que tienen una afectación radiológica mediastínica por PET o TAC, si ya lo pone en vez de o pone EUS-EUS o mediastinoscopia, pero se puede admitir en el caso de que la primera sea negativa. Hay estudios que demuestran que a baja prevalencia más rentabilidad y el valor predictivo negativo es mayor. En cambio, en otros es todo lo contrario. Lo cual creo que aquí vamos a tener que hacer un poco de arte los profesionales, y el arte, cuanto más los hagamos a la vez, mejor o más ligado está a la excelencia. En esta revisión, este consenso, Mariano lo conoce bien porque es coautor, donde hay neumólogos, también cirujanos, a mí me gusta mucho más. Dice que si una prueba de estadificación endoscópica es negativa, lo que hay que ver es si el valor predictivo de esa prueba en ese centro es o no se sabe o es menor del 90%. En ese caso habrá que confirmarlo y me parece bien. En cambio, si es mayor del 90%, tú analizas periódicamente tus resultados y sabes que se te escapan pocos pacientes y los pocos que se te escapan son lesiones microscópicas, no se te escapa una afectación extracapsular, no se te escapan adenopatías bulky que tengan más de 2 milímetros de afectación ganglionar, puedes ir con cierta seguridad y agilizar el proceso diagnóstico y la toma de decisiones. Y esto también se ha demostrado recientemente. Es un estudio, una revisión sistemática y metaanálisis de cómo es la afectación ganglionar oculta en la estadificación tras EUS con o sin técnica quirúrgica. Y los resultados son iguales. Hagas EUS solo, con EUS, o EUS con o sin confirmación quirúrgica. Es verdad que la heterogeneidad de los estudios es o moderada en el caso del estudio en la parte de los que solo hacen EBUS y alta en los que hacen EBUS con estadificación quirúrgica. Pero no nos olvidemos, las técnicas quirúrgicas, salvo manos muy expertas, tienen un 6% de complicaciones y el EBUS no supera el 1%. Y además están los tiempos, hablábamos de tiempo y forma. En el estadio 3 el tiempo corre en nuestra contra, en contra del paciente. Hay que saber, y aquí en varios trabajos que hemos hecho multicéntricos, varios grupos españoles de broncoscopistas, tenemos conocimiento, y es lo bueno que tiene la exploración, el estudio multidisciplinar, el estudio multicéntrico, te permite saber si tu PET, qué aporta el PET, qué estaciones tienes que ganar, la exhaustividad de la lesión, ¿no? Hay que ser exhaustivos en la exploración, realizando, si un tumor es derecho, una exploración empezando por el lado contralateral, yendo a las subcarinales y posteriormente al ipsilateral, y al contrario si es izquierdo. Y esto, que era una recomendación lógica, se ha demostrado. Una cosa es que hagas un diagnóstico por lo que te dice el PET y el TAC, y le uses el EBO, o sea, tiene una 4R, voy allí, es un N2, pero si vas haciendo una estadificación reglada del mediastino, empezando contralateralmente, si solo haces EBUS, casi aumentas un 5% la probabilidad de tener diagnóstico de afectación ganglionar oculta, un poquito más con el EUS y mucho más, llega a un 25%, si haces sistemáticamente los dos. Con lo cual la estadificación reglada y manejarse bien en la vía aérea, y si puedes también con el EUS-B, que es el como llamamos al acceso desde el esófago, sobre todo en tumores izquierdos, que es donde más falsos podemos tener, falsos negativos del EUS, en tumores izquierdos que no exploramos bien, las paraesofágicas o la subcarinal a veces un poco posterior se nos puede escapar y se puede acceder mejor del esófago, o el caso que les he mostrado de una anopatía 5. Y luego no hay que comprobarlos todos, hay casos en los que es evidente. Yo cuando se pide un EBUS para estadificar el paciente de las dos imágenes de arriba, me echo las manos a la cabeza. Esto es que esta EBUS negativa no me la creo. Es la misma, una masa tremenda con una adenopatía iliar, pasa precarinal, tenía otras estaciones, un paciente con además un deterioro, una pérdida de peso de 20 kilos, no perdamos mucho tiempo en hacer más que una confirmación citohistológica y una caracterización molecular por si tuviera la suerte de que en caso que lo necesitara tuviéramos una terapia dirigida. O este caso, ¿no? Con esta adenopatía en la estación 6, que su diagnóstico, por lo menos en mi centro, no sería un TEMLA o una VANLA, sería una VATS izquierda, que no se la van a hacer ni mañana, como podríamos hacer un EBUS, ni la semana que viene, porque hay una lista de espera, aunque es muy corta, de 3 semanas, son 3 semanas más el paciente esperando. Nosotros creemos que esto lo tiene que hacerse, la decisión de cuándo hay que hacer una técnica de este tipo, se tiene que evaluar, y este es un algoritmo que en una revisión que hacemos en esta revista, Virginia Leiro, que es una de las neumólogas de la unidad, y yo, en una revisión multidisciplinar, en una evaluación multidisciplinar, que hasta ahora el oncólogo pues un poco podía decirte las posibilidades, pero no tengo ninguna duda que en los próximos meses, años, y parece que son líneas terapéuticas que van a venir a consolidarse, va a ser cada vez más clave, ¿no? Y que hay que evaluar no solo si el PET es positivo, sino cómo es la muestra, qué es el tamaño de la neuropatía, qué quiere el paciente. Porque a mí me dicen que me tienen que hacer una neumonectomía y que porque tengo un estadio, un T4 N0 M0, y a lo mejor si hay posibilidades de que me hagan una quimioradio, tengo 80 años y una cardiopatía y una broncopatía leve y tal, me lo pienso. Hay que ofertarle al paciente algo más, porque esto ahora tenemos tratamientos, hasta ahora no era quimioradio a ver cómo te va con máxima toxicidad usando las líneas habituales, ¿no? Hay muchas más cosas y es un puzzle difícil de hacer, y yo creo que un puzzle se hace mejor si lo hacemos entre varios. Vamos a ver siempre 10 ojos más que 2 y 20 más que 4, ¿no? Y este es un ejemplo, mire, este es un enfermo, no recuerdo, ¿no?, de cuándo es, con muy mayor y una lesión periférica en el lóbulo superior derecho, una lesión hipercaptante que por PAF sabíamos una punción transtorácica que era un adenocarcinoma. En la estadificación solo tenía un ganglio hipercaptante con una captación de 3,8, la captación del nódulo era 12, 4L. Conseguimos meter la broncoscopio, pincharlo de forma correcta, el ganglio tiene buena pinta, no está centro hipodenso, no cambia nada, no parece un ganglio afectado, pero tal, y es claramente un ganglio linfático reactivo. El paciente es un broncópata. ¿Le harían ustedes una estadificación quirúrgica a este enfermo? Porque era un ganglio reactivo, pero para estadificarlo bien como ON2, algunos centros, siguiendo el protocolo, lo harían. El comité multidisciplinar de nuestro centro dijo que no, que le parecía muy baja probabilidad de ser un N2, y al paciente se le hizo una cirugía, incluso comentado con él, solo una resección parcial, una segmentectomía, y a los 3 días estaba en su casa y felizmente, que yo sepa, está bien y ya lleva un tiempo de tratamiento. Lo más importante de todo el procedimiento, la viñeta de todos estos pasos de la vía del diagnóstico desde que lo sospechamos, se hace el TAC, la bronco, luego el PET, la espirometría, es esta. Sin ninguna duda, es esta en el estadio 3. La sesión multidisciplinar, esa denostada que no nos cuenta en nuestras agendas, que hay que pelearse con los gerentes para que nos permitan acceder, que quién la cita, quién no cita, quién la hace, quién registra. Esa es la decisión más importante de todo lo que hacemos. Y esto no lo digo yo, lo dicen grandes expertos en revisiones muy recientes. Y en el estadio 3 es especialmente importante, y termino. Aunque la evidencia es limitada y existe mucha heterogeneidad en el funcionamiento, yo creo que si aunáramos toda la experiencia parcial que hay, conseguiríamos un gran paper donde haríamos tratamientos más activos, más acordes a las guías de práctica clínica, y esto sí hay evidencia. No tengo ninguna duda que sería más rápido el inicio del tratamiento si previamente has pactado con los oncólogos, visto y has seguido sus recomendaciones de qué crees que le podría hacer, y esto mejorará la calidad de vida y la supervivencia de nuestros pacientes. Y yo creo que con esto he dicho todo lo que quería decir. Muchas gracias.
Bueno, pues muchísimas gracias, Alberto, una exposición brillante, como siempre. Voy a dar paso a la segunda ponente, porque la idea es hacer las 3 charlas seguidas y al final de las mismas, pues el debate y las preguntas. Pues paso a presentar a la doctora Tina Castone, que es profesora asociada del Departamento de Oncología Médica Torácica de Cabeza y Cuello del Centro Oncológico M.D. Anderson de Houston, que nos va a hablar de la cirugía post-inmunoterapia. Doctora Cascone.
Yes. Thank you so much for having me and for the introduction. Can you see my slides okay?
Yes, perfect.
Okay, great. Well, thank you so much to Mariano and all of you for inviting me to this fantastic course. It's just so great to virtually see you. Of course, it would have been much nicer to be there and also I think get some flamenco. I heard that was something that was going to happen. So we're really looking forward, next time to be there again for this course. So thank you, Dr. Duar. That was really a wonderful presentation. Remembering how important is the multidisciplinary approach of early stage locally advanced disease. I was asked to give you an overview of new therapeutic strategies for early stage and locally advanced resectable non-small cell lung cancer with a specific emphasis on immunotherapy, and trying to convey, based on what we know today, why this type of therapeutic strategy might perhaps be more beneficial in early stages. So here's my disclosures. So as you all know, surgical resection is really the main preferred treatment approach for patients with stage 1 to some locally advanced resectable 3A. If we look at this pie of non-small cell lung cancer, really across the board, more than 50% of these patients will experience disease relapse if we treat them with surgery only. And over the past couple of decades, chemotherapy delivered as neoadjuvant or adjuvant treatment as a means to minimize the chance of relapse for this patient really has offered a modest improvement in overall survival at 5 years. If you think overall about the LACE meta-analysis or the non-small cell lung cancer neoadjuvant meta-analysis, platinum-based chemotherapy really gives us an absolute benefit in 5-year overall survival of 5%. With an hazard ratio of 0.89 for adjuvant and 0.87 for neoadjuvant. And so this is not good enough, okay? It's the standard of care, but we all understand that this is not good enough, and we see all our patients, or most of them, coming back to our clinics with disease relapse. You're all familiar with this, but I wanted to put some things in context to set the stage of why immunotherapy might help here. So as you all know, the primary goal of adjuvant treatment is to eliminate micrometastatic disease. The surgery takes care of the primary tumor at that time where micrometastasis. Adjuvant therapy has the role to eradicate these micrometastases and hopefully minimize the relapse. Neoadjuvant treatment has a number of potential benefits compared to adjuvant therapy. So as you can see here from the schema, neoadjuvant therapy is delivered before surgery with the hope to really downstage the tumor so that we can help our surgeons to make surgery less morbid. We can impact micrometastasis at an early time point. It's usually better tolerated. We all experience this with our patients. Is overall perhaps more doable to deliver our platinum-based therapy before surgery rather than after surgery. And then I think the beauty of this approach is really the opportunity to have an immediate readout of response with scans pre and post, and look at really what are the effects of therapy in the resected specimens when we can look at our surgical specimens before, after surgery compared to surgery, and it can give us also the opportunity to evaluate surrogate endpoints of clinical efficacy. We know that it takes approximately 8 to 12 years, right, to complete an adjuvant trial where we have as a primary endpoint overall survival to change the standard of care. So if we have surrogate endpoint of clinical benefits, so of a harder endpoint, we can perhaps investigate new therapies in this setting faster and really screen compounds that might have benefit and bring them to the phase 3 much faster. So as you know, speaking of surrogate endpoint, pathological complete response has been for a long time known to correlate with survival after surgery. We know from our breast cancer colleagues that really the PCR has been a wonderful endpoint for them to lead to the approval of pertuzumab, so HER2 therapy in breast cancer in 2013. For lung cancer, we are limited in using PCR as a surrogate endpoint because PCR occurs too infrequently after neoadjuvant chemotherapy. If you look over the past 20 years and we look at all the trials that have tested neoadjuvant chemotherapy and have looked at the occurrence of PCR, there is a median of overall 4%, from 0 to 16%. And this is just too little as a, an onset of PCR to be considered this as a surrogate endpoint at this time. So to fill this void, really, MPR, major pathologic response, defined as a less than or equal to 10% viable tumor in the resected tumor specimen after neoadjuvant chemotherapy is being proposed as a candidate surrogate endpoint, has been adopted in ongoing studies of chemotherapy, immunotherapy, and chemoimmunotherapy based on retrospective analysis. You're all familiar with the Pathological study in 2012 in Journal of Thoracic Oncology, where MPR occurred in approximately 20% of patients, specifically 19%, and really was associated with an improvement in disease-free survival and overall survival. This rate of MPR has been recapitulated in small-scale prospective phase 2 studies, and again, has been now implemented, despite not yet accepted by the FDR, as a potential surrogate endpoint of clinical efficacy. Here, I just wanted to summarize for you what I just mentioned, retrospective study from Pater and colleague at MD Anderson. At that time, I think I was in residency, so wasn't part of that study, but it really tells you, but if you look at A and B and the Kaplan-Meier curves, the impact of an MPR and the separation of the Kaplan-Meier curves when you look at patients who received neoadjuvant chemotherapy and achieved major pathological response as compared to those who didn't, in terms of benefit for overall survival and recurrence-free survival. As I mentioned, this has been recapitulated in small-scale studies. We perform a neoadjuvant trial of platinum-based chemotherapy followed by adjuvant erlotinib, and you can see again that patients who achieved MPR had a major benefit with longer overall survival as compared to those who didn't, with a trend also toward improvement in disease-free survival. These are small cohorts, but definitely are encouraging. In ENF, I wanted to just mention that in cases where MPR is not achieved as a better, as a surrogate of clinical efficacy, you can still see how in patients who had a tendency to have MPR or had major pathological regression, you have an improvement or a tendency to improvement in overall survival as compared to who didn't. So solid retrospectives and a small scale prospective data to implement MPR as a suitable surrogate for improved survival after neoadjuvant chemotherapy at this point. So why immunotherapy might work better in the neoadjuvant setting when the tumor is still in place? Well, the efficacy of immune checkpoint inhibitors to produce an anti-tumor immune response with the goal to trigger memory and minimize the chance of relapse by eradicating micrometastatic disease depends on the ability of the T cells, right, to recognize tumor-associated antigen. So if the tumor burden, which is in the neoadjuvant or perioperative phase, is the greatest prior to surgery when there is macrometastatic disease, so the neoantigen load should be. And so that's where you see the advantage of potentially delivering immune checkpoint inhibitors prior to surgery as compared to an adjuvant setting. Swanton did an amazing body of work over the past few years where with his team demonstrated that really in the primary adenocarcinoma of the lung that are in early stage, there is a higher load of clonal neoantigens, immunogenic neoantigen that are able to trigger a specific CD8 effector cytolytic anti-tumor immune response. And this is much more beneficial to prolonged survival compared to those tumors that are treated when they have a subclonal neoantigen load. So that's very important. If we think about this as a potential important mechanism to deliver immunotherapy when the immune system of our patients is fit, prior to surgery, prior to additional chemotherapy that has been shown to induce subclonal neoantigens. And then PD-L1 on cancer cells has been shown to actually induce a CD8 positive tumor-infiltrated lymphocyte dysfunction and promote metastasis. So if you think about the preoperative setting as the window of opportunity to deliver immunotherapy, this last bullet makes a lot of sense, because what is going to create, is going to induce relapse locally or distance is the micrometastasis. So if we can eradicate this process by delivering immunotherapy early on, we could set ourselves in an advantageous position. This is what I just mentioned. So Gibbons and Chen at MD Anderson a few years ago, they performed this elegant work where basically they saw that PD-L1 expression in murine models, syngeneic models of adenocarcinoma, is responsible for CD8 positive TIL dysfunction. When we perform genetic targeting via shRNA of PD-L1, we can definitely reduce the metastatic lung nodules, we can reduce tumor masses, and we can suppress metastasis and restore CD8 positive TIL function. Most of you are probably familiar with this work published by the Australian group a few years ago, where really the first evidence in the preclinical setting that neoadjuvant combined immunotherapy is superior to adjuvant at eradicating micrometastasis and really in triggering a sustained anti-tumor immune response. They did an elegant work in really testing a combination of immune checkpoint inhibitors and additional immunotherapies in specific murine models of breast cancer, where you can see they basically observed a prolongation in survival as compared to in the neoadjuvant setting as compared to the adjuvant setting. So what about the clinical setting? Well, Ford and colleagues 2 years ago published on the New England Journal of Medicine the results of the pilot study in a very small amount of patients, where we really appreciated the safety, the feasibility of delivering nivolumab, an anti-PD-1 drug in a population of patients with resectable non-small cell lung cancer. They employed MPR as an endpoint of the study after feasibility and safety. As you can see from the waterfall plot of percentage of regression, the MPR was observed in 45% of patients, so 9 MPR on 20 resected patients. I wanted to point out here that the denominator, because this is an important point, is the resected population of patients. And they also saw, as you can see in B and C, immune infiltration after surgery that really opens the door to a number of investigations for understanding what are the immune-mediated mechanisms that can lead to MPR or to resistance in this setting. The LCMC3 presented by Dr. Kwiatkowski last year at ASCO investigated 2 doses of neoadjuvant atezolizumab PD-L1 inhibitor in producing MPR in 19% of evaluable non-oncogenic driven non-small cell lung cancer, so a lot of patient selections here. And you can see how encouraging is that really a number of patients, despite not achieving MPR, had a solid degree of profound degree of pathological regression. Safe, again, in this case, really, if you look at the safety population of 101 patients, really only 6% of grade 3 or greater treatment-related adverse events, mainly pneumonitis, lymphopenia, and anemia. So pretty much no new safety concerns with these agents compared to what we have learned from the first-line metastatic setting. Just a couple of months ago, the Asian group led by Gao and colleagues published the results of the PD-1 inhibitor sintilimab in an Asian population of 40 patients enrolled, 37 patients resected. Again, we see the rate here of 40.5% in the resected population and on the intention to treat. They also had some very nice translational analysis looking at the correlation between pathological responses and SUV max at PET, which is something that is triggering a lot of interest in terms of understanding what is the role of tumor metabolic glycolytic uptake pre and post neoadjuvant therapies. Well, what about combination immunotherapy? I mentioned to you that there is experience in the neoadjuvant versus adjuvant in breast cancer preclinical model. What about in lung cancer in the clinical setting? We all know about the Checkmate 12 results published in 2017. That was really the first look at the safety and initial objective response rates of PFS with combination of nivo plus CP versus combination of versus nivolumab monotherapy. So definitely the combination overall safe and more active with increased objective response rate and prolonged PFS. Hellman also published on behalf of the BMS International team the results of the checkmate 227, where we see here from the part 1A, and don't forget about the part 1B also with the PD-L1 negative population, but here with the PD-L1 positive population for first line non-small cell lung cancer patients untreated, the combination of Nivo plus EP in the front line led to an improvement in overall survival as compared to chemotherapy. So from here, going back to our neoadjuvant and early stage locally advanced resectable disease, we launched the New Star study, which was the preliminary clinical data were presented last year at ASCO. You can see that 44 patients are eligible with stage 1 to 3A and 2 single stage on based on the 7th edition, based on when the trial was launched. Surgically resectable with a good performance status, stratified by stage, were randomized 1-to-1 to receive nivolumab at 3 mg per kg for 3 doses versus nivolumab plus ipilimumab with ipilimumab anti-CTLA-4 drug given only on day 1. So that's an important point also to remember, especially when we think about the translational analysis and when we want to put the results in context across what's known with these therapies in other diseases. After 3 doses of therapy, patients underwent surgery. Primary endpoint of the study was MPR, 10% or less viable tumor in the resected tumor specimen, hypothesized to be superior to historical control of neoadjuvant chemotherapy, conservative rate of approximately 15%. I just mentioned to you 19% in the MD Anderson cohort. If you think about the dropout rate and really who gets to surgery, that was set at 15%. Number of translational analysis, baseline CT, PET-CT, baseline tumor, mostly archival. It's very difficult to mandate rebiopsy in a curative population of patients where we have already a diagnostic specimen. Blood collected pre-surgery, pre-therapy, as well as longitudinally, and a stool for gut microbiome analysis. Post-treatment, prior to surgery or a surgery again, radiological evaluation, collection of blood, stool, and tumor, and uninvolved tumor adjacent lung at surgery, as well as additional blood collection within 8 weeks post-surgery, when is usually when we tend to see our patients for recommendation of adjuvant systemic chemotherapy if needed, or a port. So these are the data presented last year at ASCO. So in the overall intention to treat population, so with a denominator of 44 patients, MPR rate overall were 25%, 17% in the nivolumab group, and 33% in the nivolumab plus ipilimumab group. So very similar with the single agent monotherapy to what I show you for the with the LCM C3. Just for the sake of time, I didn't show you additional monotherapy data. The pembrolizumab alone has been recently presented last year at World Lung, 28%. The pembrolizumab in the phase 1 study has been recently presented, approximately 35% MPR rates. So you can see here from the stack bar, I really try to convey the magnitude of the benefit between the 2 arms. The pre-specified trial efficacy boundary was an MPR of 6 or more to consider the regimen promising for further evaluation. And you can see from this initial data that combination therapy with nivolumab plus ipilimumab crossed the boundary with 7 MPR, including the PCR, 29% rate versus 9%. And so it met the pre-specified trial efficacy boundary to be considered promising for further evaluation. And in an exploratory analysis, you can see that when we look at the evaluable population of patients resected on trial, that those percentages go up to 19% MPR for nivolumab and 44% for nivolumab plus ipilimumab, with a very encouraging PCR rate with the combination of 38% as compared to 10% with the single agent nivolumab, which is much closer to what we're used to see or perhaps slightly better with neoadjuvant chemotherapy. And you can see that evaluation of a percentage of viable tumor in resected specimen and surgery also demonstrated a lower median of viable tumor cells in tumor resected after combination immunotherapy as compared to nivolumab monotherapy. Overall safety here summarized from ASCO presentation last year, mainly grade 1, grade 2 toxicities, and a non-new safety concern with perioperative surgical complications that are not different from what we have seen in the last, in terms of rates, the last 20 years with the major neoadjuvant chemotherapy trials. And Dr. Spicer will do a much better job that I could do in educating us about what we have learned so far in terms of surgical outcomes and surgical consideration in this setting. So I just wanted to take a moment to pause and think about, with the clinical data and what we've learned so far, what are we missing for early stage resectable disease? And what next steps we should take to really make a global effort to harmonize and standardize how we look at these surrogate endpoints and what else is needed to improve these outcomes. So first of all, it's something that we that I hope I convey with this data so far. There is an intertrial variability when we look at MPR. So far, when we look at the data with monotherapy, MPR range is 17% to 45%. We're talking about slightly different drug. We're talking about the same immune checkpoint axis. So why are we seeing disparate rates? Is it because we are looking at different denominators, intention to treat versus resected population? Does the histology matter? Does the type of therapy matter? Does the pathological analysis matter? And for sure it does. Over the past year or so, the International Association of Study of Lung Cancer, Mariano and myself are a part of this effort, really is trying to, again, harmonize and standardize how the pathologists should, first of all, ask the surgeon the specific type of specimen for a standardized analysis, what type of sectioning should be done, how is the MPR supposed to be analyzed to harmonize the rates across the board. Does TMB matter, tumor mutation burden? Is this something that could matter in the neoadjuvant setting, especially for what we have just discussed, macrometastatic disease present before resection as compared to micrometastatic disease after surgery? Does the PD-L1 status matter? Does the immune contexture of the tumor matter, or the TCR repertoire features? Can we use circulating DNA as a potential biomarker of response to evaluate residual disease, microscopic residual disease that can inform us about the patient who will relapse or not after this therapy? And can we incorporate radiographic information to predict response? So these are all important points I wanted to discuss and put the data in context to really trigger discussion in terms of translational aspects of this effort. So Bill Travis and colleagues from Memorial Sloan Kettering published last year very elegant analysis on retrospective tissue specimens of non-small cell lung cancer, squamous cell, and adenocarcinoma analyzed after neoadjuvant chemotherapy. And what they demonstrated by looking at lung cancer-related survival is that perhaps we might need different MPR cutoff to predict survival in adenocarcinoma as compared to squamous cell carcinoma. Perhaps a 10% is not ideal across all histologies. And so that's something that, of course, has been performed retrospectively. It needs to be validated prospectively, but it really helps us to question the biology of the tumor might not be neglected when we look at the MPR as a surrogate endpoint. Hanika Westford and Pater, and I'm sorry, this is no longer under revision, it's been accepted at lung cancer just a few months ago. they really move forward again a major retrospective effort looking at non-small cell lung cancer patients treated with neoadjuvant chemotherapy across a decade at MD Anderson, so hundreds of patients, and they really show with this report how important it is to be trained as pathologists to evaluate MPR, and how important it is to evaluate at least 3 slides per tumor to understand really what's the tumor necrosis, fibrosis, inflammation, and make an assessment of MPR. And again, you can see here, patients with MPR after neoadjuvant chemotherapy had an improvement in survival as evaluated by Observer 1 and Observer 2. Tricia Cottrell from Hopkins group with Patrick Ford and Janice Tabby did a fantastic job in trying to really understand whether perhaps we should look at different features when we evaluate the major pathological response after neoadjuvant immunotherapy as compared to adjuvant chemotherapy. Perhaps we should look at not only the tumor area, the entire tumor regression bed, and look at a number of other characteristics of the tumor, including the cholesterol clefts, the TLS, the tertiary lymphoid structures, granulomas, fibrosis, neovascularization, because perhaps this assessment can lead to a better evaluation or a more accurate evaluation of the tumor immune response after neoadjuvant immunotherapy as compared to neoadjuvant chemotherapy. Again, this approach has to be validated. Just a few days ago at ESMO, I think on Saturday night, the Princeps data were presented with the durvalumab neoadjuvant therapy by the Gustave Roussy group, MPR of 14%. I wasn't quite clear whether that was the resected population or not, but for that assessment, the Cottrell criteria were used. And so I'm really excited to see how this will play out in terms of validating that data with the Pathological criteria and cross-validate these cohorts, because that definitely can lead to important changes on how we look at the specimens and elaborate on the MPR. Westford and colleagues at MD Anderson evaluated retrospectively a new cohort of resected specimens treated with neoadjuvant chemotherapy or neoadjuvant immunotherapy. They look at the exact same characteristics of the tumor as the Cottrell criteria. And while definitely, as you can see from the bars on the right, you can definitely see that in the untreated tumor, there was more viable tumor, but really overall in the chemotherapy treated tumor as compared to the IO and as compared to the untreated, less viable tumor in the IO treated as compared to the untreated and the chemotherapy, and definitely a more amount of necrosis. So that's something that again triggers food for thought in terms of are we missing something? Why the cohorts, the analysis with the same criteria of different cohorts lead us to different results. And of course, these are retrospective analysis, and that's where the phase 3 randomized trials come in play in terms of validation and future studies. I mentioned to you about role of TMB and PD-L1 correlations with MPR. So I wanted to put things in context because that's very important. Ford and colleagues really observed correlation with the TMB and the major pathological response in their pilot studies. This did not happen for the LCMC3, as you can see in the middle, presented by Kwiatkowski. It didn't matter, the amount of mutation to achieve an MPR. And as you can see on the right, as far as the PD-L1 by the 22C3 antibody was correlated with pathological regression. We performed preliminary translational studies in collaboration with Ignacio Wistuba, the MD Anderson, just wonderful mentor since more than a decade for me, and collaborator, where you can see that a baseline percentage of tumor, so malignant cell PD-L1 expression correlated with radiographic responses, as well as a higher degree of pathological regression. Of course, keep in mind that these are studies done in a small group of samples, because what I mentioned at the beginning, across all the studies, it's very difficult to obtain fresh tissue biopsy at baseline that are sufficient and appropriate for translational analysis. So again, the relationship between PD-L1 and TMP has to be determined in future studies. Shu and colleagues in the recent publication with the atezolizumab and chemotherapy on Lancet Oncology did not find an association, a significant association between radiographic responses and baseline PD-L1. And we also, as you can see here, found PD-L1 responses in patients who had very low PD-L1 or lacking PD-L1. So take this data with caution across the trial. That's something that has to be validated in the phase 3 setting. Well, what about the early ctDNA clearance? Is this associated with pathological response? Ford, Pardol, and colleagues have presented as part of a frontline cohort and as a sort of validation cohort in a recent publication, they noticed that a ctDNA at diagnosis and NPR does not associate with RFS, but it's important to consider perhaps to catch the ctDNA early on after surgery to understand whether there is really a correlation with long-term survival. Well, where are we going with this data for the resectable stage 1 to stage 3A or 3B with the AJCC 8 resectable and 2 single station? The NeoCOAST is a platform study, is a phase 2 study led by MedImmune, AstraZeneca, Dr. Spicer, and myself are part of the studies with a number of other investigators, Rosario, Garcia Campello, and other members, where we're really using this platform to test a backbone of anti-PD-L1 inhibition with durvalumab for 4 weeks as compared to a combination of immunotherapy regimens, chemotherapy sparing. And this is a beautiful platform, in my opinion, really to learn about biomarkers and the translational information that can streamline the next generation of trial. This is, again, is using the NPR as primary endpoint. And we're really looking forward to see how the data is going to play out. So, well, what's next? What about the combination of additional strategies with immunotherapy? Can we do better than that, also looking at the NPR? So Ignacio Wistuba's group with Edwin Parra published a couple of years ago a very nice retrospective analysis using hundreds of patients that have been treated with MD Anderson with neoadjuvant chemotherapy, and by implementing VETRA, so multiplex immunofluorescence staining, and looking at survival outcomes, was able to demonstrate that the administration of neoadjuvant chemotherapy is associated with an increase in the PD-L1 tumor expression. And that tells you really how would make really so much sense to perhaps implement additional strategies in this setting to achieve cytotoxic effects, immunogenic effects, and trigger memory. These are the data that you're all very familiar with from Mariano's and his team effort, unprecedented data from the Nadim. I have here trying to put in context the radiographic data and the major pathological response and the complete pathological response data. So overall, partial, objective response rate of approximately more than 70%. Which is pretty much in alignment with the high end of what we have learned retrospectively over the past 20 years, 40 to 60, 65% across the trial. But really what's striking is 83% NPR after 3 cycles of nivolumab plus platinum-based chemotherapy with paclitaxel and carboplatin in stage 3A resectable disease, and with a 59% of pathological complete responses. The Columbia's group has published a few months ago on Lancet Oncology, and Mariano, I'm sure that I will congratulate you soon. So with atezolizumab plus chemotherapy in stage 1B to 3A, again, 4 cycles in the setting, 2 scans and 2 additional cycles with nab-paclitaxel, atezolizumab, and carboplatin. Again, objective response rate in the order of 60–65%. Pathological complete responses in the intention to treat population of 57%, with a PCR of 33%. That is very similar to what I showed you at the beginning, what we see with the combination nivolumab plus ipilimumab. These are the survival outcomes at this point in time. So very encouraging overall survival and event-free survival from the MAX study on the left and Nadim. I just wanted to point out with the Nadim study at 18 months and overall survival over 90%. So absolutely encouraging for this population of patients. Just wanted to give you here really a summary of selected immunotherapy-based trials in the neoadjuvant and perioperative space, and especially with emphasis on the fact that the landscape for the perioperative space has moved so fast to a pace that is really much faster than what we are used to do in the clinical setting. Translational research has become paramount to really streamline the next trial. And this really gives you an example of the effort, what we have learned from the Nadim led to Nadim 2, what we've learned from the NeoStar led to an extension of the NeoStar that I'll tell you about it. We are really testing multiple immune checkpoint inhibitor with multiple combination of chemotherapies. We're testing different type of immune checkpoint inhibitor, multiple immune suppressive inhibitor agents. If you think about the canakinumab with the Canopy drug interleukin 1 beta inhibitor. So we're really expanding our ability to implement the science in the perioperative setting, which is great, to me. Checkmate 816, led by BMS, and I know Dr. Spicer is heavily involved with this trial with the Hopkins group. This is a phase 3 study of neoadjuvant immunotherapy plus chemotherapy with nivolumab plus chemotherapy versus standard of care platinum doublet, randomized 1-to-1. Initially also a third arm with the combination of nivolumab plus ipilimumab that is no longer recruiting. We are all looking forward to see the initial data of this study that I'm sure will be presented sometime soon. Primary outcome measures here, it's important to mention, EFS, so a hard endpoint, as well as a PCR. This will allow us definitely a potential validation for the FDA to consider this surrogate endpoint in the prospective large phase 3 setting. Wanted to give you here really an overview of the ongoing phase 3 peri-adjuvant studies. I know the Nadim 2 is adopting a similar type of platform. I focus here on the phase 3, so think about the Checkmate 77T with the nivolumab plus chemo as compared to chemotherapy standard of care, 4 cycles, EGFR mutation and ALK fusions are not allowed. This is really important to mention. I know we're focusing on immunotherapy. We cannot neglect the data just published, I think a few days ago in the New England Journal of Medicine from the ADORA trial, Tagrisso in the adjuvant setting for an EGFR mutant population with an unprecedented hazard ratio for disease-free survival across stage 2 and stage 3 of 0.17. Keynote 671, pembrolizumab, EFS and OS as co-primary endpoints. These are very large studies, as you can see, from approximately 4,500 to 7,800. The Empower 30 with the atezo MPR and EFS as co-primary endpoint, and the Aegean. Please keep in mind that the Aegean has expanded enrollment. I think we are almost at 800 patients, or 750, and as updated the primary endpoint as co-primary, again, EFS and MPR, because it's very important to allow the FDA, the regulatory agency, to have a hard endpoint with a surrogate endpoint for validation. I also wanted to point out that stages are slightly different across the trial, and adjuvant immunotherapy with each agent is allowed for approximately 1 year. Also wanted to touch base on the adjuvant setting just very quickly. Let's not forget that approximately 10–15% of our patients are upstage when they get surgery up front. So we're really all adamant about seeing the data of the adjuvant nivolumab, perhaps slightly obsolete at this point with the Anvil. I know Jamie Shaft has amended to implement also the endpoints into the PD-L1 positive population. The Empower 10 with the Atezo in the adjuvant setting, the BR31 with the Durva, and the Pearls with the Pembro, and then there are a couple of other studies, again the Canopy and the Samsung study with the Pembro. They all, as you can see, have the typical primary endpoint. When the disease has been resected, we can only follow our patients with disease-free survival, and for the Anvil, overall survival. Checkmate 9LA, you're all familiar in the frontline setting for treatment-naive advanced metastatic non-small cell lung cancer across histology, across PD-L1 status, an improvement in overall survival with an hazard ratio of 0.66. So 34% reduction in risk of dying with Nivo plus EP plus a short-term chemotherapy, 2 cycles as compared to chemotherapy. I think this is has been approved, it's FDA approved. So it's a practice-changing type of trial, especially if you look at the population of patients where you do not want to continue chemotherapy for long-term, and you want to have a priming plus cytotoxic effect and continue the immunotherapy. Why did I mention this? Because I think we can learn from the safety and activity and efficacy in the stage 4 to bring, of course, this information in the neoadjuvant setting. The new STAR has been amended to a platform design after the first randomized phase. Now we have an arm C with the nivolumab plus chemotherapy, and an arm D with nivolumab plus low doses ipilimumab for 1 cycle plus platinum-based chemotherapy. And really this will help us to elaborate on how does the platform of therapies that we can deliver in the metastatic setting affects major pathologic response, safety, surgical resectability in the neoadjuvant setting. Remember, for these arms C and D, we're talking about implementing chemotherapy, so stage 1B, 4 centimeters or greater, it's what is allowed. So we have learned that there is a role for neoadjuvant and perioperative immune checkpoint inhibitors for stage 1 to 3A resectable, I should say 3 overall resectable disease. We have a lot to learn yet, so I wanted to leave you with some food for a thought. We really don't know what's the best therapy timing across all the trial. We have 1 cycle, 3 cycles, 2 cycles, a different window from last immunotherapy dose and the surgical resection. Shall we use these agents in sequence versus combination? If we think about the science, if we think about potential immune checkpoint upregulation, where we block one immune checkpoint, another one might come up. This is something that has been published extensively in the metastatic setting, in preclinical models across melanoma, renal cell, and non-small cell lung cancer. How can we modulate the immune microenvironment with these therapies? These are all questions that are under investigation. Can we implement new drug? So we need to investigate the safety and the feasibility of potential STING agonists, intratumoral IOs, CTLA-4 best combos, and these are all questions that are being answered with early stage trials. I can't emphasize enough how important, at least is for me as physician scientist, biomarker discovery. I think without translational science, we cannot really design the best next trial. So a lot of studies, a lot of effort undergoing to look at the PD-L1 in the stroma, in the tumor cells, TMB, all these trials, this is an effort that I'm sharing with Dr. Spicer, performing single cell RNA sequencing analysis to look at the transcriptome at the TCR, BCR evaluation at the single cell population level. We're looking at ctDNA analysis. We're looking at microbiome. Again, oncogenic drivers cannot be neglected. We cannot just put this patient all in one bucket. They're all going to be distributed in different buckets so that we can align the best inhibitor for their driver. Radiomics is something that is really being explored with so much interest across the studies. If you think about how readily usable can be a scan in the clinic to inform us about what type of immune microenvironment we can have. Should we even disposition these patients if we know about their radiomic features to immunotherapy, to chemoimmunotherapy? Should we take them directly to surgery? Or should we treat them as a metastatic disease up front? Again, we're validating the surrogate clinical endpoints in phase 3 trial, and with Mariano, Ignacio, and the International Association for the Study of Lung Cancer, we are all having a major pathology effort to really look at all the trials that are available, to have multiple pathologies, look at those in a blind manner, and develop new guidelines, new algorithm that can be implemented in the further studies, of course, with the FDA input. And then last point that I wanted to leave you with, very important to trying to understand whether we should report these endpoints in intention to treat population. That's something I've discussed with Mariano, brainstorm on it multiple times. It makes sense to think that the patients who did not undergo surgery might not really be part of that population, because we will not know whether or not the neoadjuvant chemotherapy has really, done anything on that tumor. But it's an intention to treat. We treated those patients. So something that I wanted to stimulate thoughts on it, because we don't have an answer for, but it's important to think about it. And so with this, I wanted to thank really a number of colleagues and collaborators, and thank you for having me to brainstorm with you today about this topic. Thank you.
Thank you very much, doctora Casconi. Y ahora ya pasamos al tercer y último ponente, que es el doctor Jonathan Spicer, que es cirujano torácico y gastrointestinal y profesor asociado de la Universidad de Mcgill, que ahora sí nos va a hablar de la cirugía post-inmunoterapia.
Dr. Jonathan Spicer, we can't hear you.
Sorry, I was having a slight technical difficulty. Okay. Can you hear me now?
Sí, yes, perfectly. Thank
Very
you.
good. Primero, quiero disculparme por no poder presentarme en español. El cáncer del pulmón en etapa 3 ya es bastante confuso. Sería aún más complicado para mí en español. So first of all, thank you very much for having me to present here. It's a real honor. I've been following the stories from Spain for quite some time in this area. I think you guys have been absolute leaders, and so it's just a privilege for me to get to spend some time with you to share some of my thoughts on this exciting topic. So these are my disclosures. As I think has been discussed, and it's not getting any simpler, locally advanced non-small cell lung cancer is a very gray area of care in our tumor boards, which are the basis for all of our decisions in this area. There's a lot of intense discussions. I like to think of it as a platform for discovery and a way to address a lot of the challenges we have in lung cancer more broadly speaking. And so locally advanced lung cancer, as you know, is a big part of what we do. At least a third of our patients present with this stage. And I think what we can say from what we've learned in the last 30 years of care is that the path to the best possible outcomes is through multimodality therapy. And I think Dr. Cascone and I went to the same church. We have the same beliefs, I think, around this, and it's certainly what's been taught at MD Anderson. And that's there's a long-standing history there. Dr. Roth, who's a real mentor for me and one of my idols in thoracic surgery, was one of the first to demonstrate the clear value of systemic therapy for locally advanced non-small cell lung cancer, which is indeed a systemic disease. This was back in the early 90s, where they randomly assigned patients to perioperative chemotherapy or surgery for stage 3A. And this study had to be stopped halfway because of the extreme benefit of the administration of chemo. That was true both for disease-free survival as well as overall survival. And despite this, for the last 30 years, there's a continued thought among surgeons and other clinicians as well that neoadjuvant therapy may actually be a missed opportunity for cure. And even then, at that time with those regimens, progression on protocol was only 15%. There was some issue with resectability, but I attribute that more to the staging and imaging investigations that were available to folks back then. But in this context, there was still a quite high R0 rate amongst patients who did make it to surgery, with a 90% R0 rate. These results were replicated by the Spanish group out of Barcelona the year after, and essentially identical outcomes. So clearly systemic therapy was of great value. I can't really give a talk about locally advanced lung cancer without mentioning the Albane Trial, which is, I think, familiar to everyone, because this really set the tone for about 20 years of patterns of practice. And in fact, at our tumor board, when I came back in 2015, it was sort of heresy to suggest that you might operate on a patient with N2 disease, despite the fact that we have fairly clear advantage. And so, we're still struggling with this concept that chemoradiation alone as a modality may be all that's required for stage 3 patients. I felt the need to challenge that as a fellow, and brought a team of a few different centers. We were able to amalgamate data from Memorial Sloan Kettering, MD Anderson, Swedish, University of Toronto, and Mcgill. And of course, this is non-randomized data, but it's real-world data from some high-quality centers where patients were either treated with chemotherapy, because that was sort of the culture at one set of institutions, versus chemoradiation in another, and it was really impossible to find a survival difference between these two cohorts of patients. So the concept of providing optimal local therapy and pairing that with optimal systemic therapy is certainly something I believe in, and I think is supported with good data. When I started as a staff surgeon in 2015, it really felt that multimodality therapy for locally advanced lung cancer had hit a plateau. We weren't really seeing any major changes. It was sort of rearranging the order of things, but without changing outcomes all that significantly. And then these things happened. IO came to the curable stages of disease. And the publication of the Pacific trial revolutionized care for inoperable patients, to the extent that there's even a suggestion that this approach may be sufficient and optimal for patients who could undergo an operation, and that question is certainly still open. Then, as Dr. Cascone very elegantly discussed, the advent of neoadjuvant immunotherapy has completely changed the landscape. I think that without reiterating a lot of what's been said, I think these adjuvant trials, these are just a few of them, are critical, because no matter what we do in the neoadjuvant space, we will continue to have patients with incidental N2 despite all our best attempts.
Lo que no he podido es que estoy en un congreso y lo he visto así, no he entrado en la página, o sea, he visto la página, pero no he entrado a leerla. ¿Es la del IAB? Sí.
All right. So yes, in fact, while these adjuvant studies are important, one of the challenges is the duration of time that it takes to achieve outcomes for these, and the numbers required, the sheer cost of running these trials. And then, Dr. Cascone touched on this as well, the importance of assessing major pathological responses as a surrogate endpoint, I think, is part of what has fueled the massive interest in neoadjuvant protocols and the tight association of this surrogate endpoint with survival. And I think that it is part of what's explained the massive interest. As we all know, the linear iterative approach to clinical trials means that things take a long time to result, and people are excited about the notion that maybe there's a quicker way to achieve some answers. So this is something we just put out last month. It is sort of the Wild West here with all of these studies. And I think, although it's extremely exciting, we're already seeing the extreme heterogeneity in this in our surrogate endpoints. And again, Dr. Cascone touched on this and explained it quite nicely. We have issues with heterogeneous stage inclusions. We have low patient numbers. We have broad variability in the number of cycles, the number of agents being used. And so it's easy to get confused. But what is clear is that these protocols, by and large, are biologically far more efficacious than any of the conventional regimens. Even if you were to look at SWOG trial for pancreas tumors, where high-dose radiation is combined with chemo, the highest rates of complete response are in the 50% range. And so these are being exceeded handsomely by much easier to tolerate regimens that are purely systemic in nature. And again, I think this issue can't be overstated. Part of what's going to lead to ongoing confusion is that this paper, which was a consensus piece on how to assess major pathological response, came out this January. And all these studies are in play for now many years, and will result with various protocols, not necessarily 100% alignment in terms of how we assess pathological response. As if you just look at these diagrams and you take a moment to speak to your local pathologist, you'll understand to what extent this is a complicated endeavor that has our pathologists spending extra time, a lot of extra time on these specimens, and sometimes struggling with decisions despite these recommendations when we try to do things in a aligned fashion. So I think, the next few years will be characterized by trying to put patients on these protocols, because I think most people are convinced that they will bring benefit, but it's a complicated affair. Who do you enroll on these trials? How do you get them to meet enrollment criteria? Because this is not a simple thing. It's not like standard of care where all you need is an EBUS of the highest nodal station, and that's enough to go ahead and enroll and start them on systemic therapy. These patients need dedicated biopsies, and that can be complicated. Getting all the investigations in a timely fashion is not easy, depending on which medical system you're working in. The questions about the operation itself, will they make it to surgery? This is an ongoing debate. Again, Dr. Cascone talked about the denominator. They look great when you look at the people who made it to surgery, but things are different if you include those who didn't make it. What can we do to ensure that patients get to surgery? How do we layer these interventions with other things to facilitate that for the patient? These are all very important questions. Will the surgery be more complicated? Well, surgery for locally advanced disease and lung cancer is always complicated, whether you have preoperative novel unknown therapy, radiation, or upfront. They're not easy operations. And then how do we address the evolving molecular landscape? Because targeted therapies are going to come to the early space, and the relationships with IO that we're seeing in the stage 4 setting are going to become increasingly relevant. And I have a couple cases to show you about how important these issues become. So just to let you know a little bit about our experience at Mcgill, as I said, when I started in 2015, there weren't many stage 3 patients being operated. If they did, it was after chemoradiation. It was only low volume, single station disease. And it was sort of, I had to really convince people that there might be value in alternate ways of doing things. And in 2017, we opened our first protocol. And since then, we've enrolled about 78 patients, if we include both those who are on and off, like on standard of care preoperative chemotherapy. So we've been busy in this space. We had one death during that time, and I can talk a little bit about that. Actually, it just happened this spring. It's close to my heart because it was my first in-hospital mortality for a patient treated with neoadjuvant therapy. Tested COVID negative the day before surgery. The operation went well. He had a minimally invasive sleeve left upper lobectomy and developed COVID during his admission and passed away a few days later. So the new environment may impact some of our decisions. It's not going to get easier in the pandemic era to deliver some of these treatments, and it does cause some pause. Our complication rate, our major complication rate from standard VATS lobectomy is about 10 or 11% in our center. In these patients, we have about a 17% major complication rate, but they are generally more complex operations. So we'll have to really wait for the phase 3 data to decide whether or not the neoadjuvant agents themselves are inducing a higher complication rate. But I feel like we're within what might be expected. Only about 40%, in my practice, about 90% minimally invasive, but with these patients, whether it's chemo or chemoradiation, immunotherapy, IO, generally, even at presentation, the patient is more likely to have an open surgery in my hands. And I'll say a few thoughts about that. But in this series, about 40% or so will have had a minimally invasive operation. And as you can see, quite a few have had complex resections, extended lobectomies with vascular sleeves, bronchial sleeves, chest wall resections. And we really do make an effort to keep our pneumectomy rates as low as possible. So of those 78, we've had 27 who've been on protocols, and the 3 main ones that we've had open over the last 3 years are Checkmate U16, Keynote 671, and NeoCoast. I'm proud to say that 100% of our patients have gone on to surgery, and that's not to say that there have not been some who were delayed and that required some significant tender love and care. But we did manage to get them all to the operating room. As I mentioned, we had this one operative mortality more recently. And there are some challenges, just logistically speaking, for getting patients on protocols. Quebec is a big province. We're a referral center in downtown Montreal, but at least half of our patients come from an hour or 2 out and have to drive in quite a distance. And there are peripheral hospitals that offer systemic therapy off protocol, and there aren't too many patients will travel to come have their operation done downtown, partly because that's the only place it can be done. But they are more reticent to have multiple visits for trial mandated investigations and also systemic therapy. The peri-adjuvant design, I think, also impacts that. So a patient who now has to come in for a full year to get their adjuvant PD-1 inhibitor, it's a big commitment. Blinded designs are sometimes problematic for our patient population, and definitely the need to rebiopsy for third-party testing can add an element complexity that some patients are not interested in being a part of. So some of my thoughts around staging that relate to this issue of protocols. So I'm a strong believer that at least until we have our somewhat mature phase 3 data and better idea of the biological efficacy and mature adverse event data, I think teams should really focus on enrolling patients into these trials who are operable at presentation. Enrolling a patient who is borderline resectable with the hopes that whatever neoadjuvant regimen they end up being assigned to will make them resectable, I think is a little bit difficult at this time, and can lead to some problematic situations and patients not actually making it to surgery. And I think now, especially with the Pacific protocol coming, that there are alternatives for patients that we do have to consider carefully for these borderline cases. I think it's really critical, and I enjoyed Dr. Fernandez's talk. I think that teams should really identify eligible patients as early in their trajectory as possible because of this issue of unnecessary diagnostic and staging procedures. And in order to give patients the best chance possible of being on a trial, they need to be worked up in such a way that they don't need to repeat these procedures to get there, or at least minimize it. I think when I'm a big fan of endobronchial staging investigations, I think it's important for those who are doing those procedures to understand that, at least for the time being, most trials are asking for histological quality specimens. So if there's endobronchial tumor, take a bunch of chunks of it so that there's abundant specimen in your pathology lab to share with third-party testing if the patient is going to be on an industry-sponsored trial. Make sure you have 19 gauge needles available and that you try and take some cores of the lymph nodes if you can. And I do think that while EBUS is the optimal way to stage patients, it's important to keep a path to mediastinoscopy. And just for expediency, sometimes a failed EBUS or an EBUS that didn't sample a level 2 node that's positive on PET, because for whatever reason the PET was done after the EBUS, which sometimes happens in our system. Well, sometimes just going directly to mediastinoscopy from there can be a helpful thing to avoid too much spinning of the wheels before we get to initiation of treatment. Now, the question of restaging, I think, is highly, it's actually quite a complicated question. In the era before immunotherapy, I think surgeons fell into two cohorts. There were those who were heavily participant in the Albane trial and it really didn't want to operate on patients with persistent N2. And there were those who would be fine to operate even if there is persistent N1 or N2 disease. I'm of the latter cohort. I think that while persistent nodal disease is poorly prognostic, it doesn't mean that there isn't still benefit to complete resection of the primary tumor and its lateral nodal disease. So I don't tend to advocate for restaging. I think there's a few circumstances that actually Dr. Cascone's teams described well. I think the concept of nodal immune flare is very real. And for me, the indications to restage in that context are when the flare is indicative of potentially unresectable disease. And so even though it might just be inflammatory, I think it's worthwhile to restage in those to make sure we're not doing unnecessary surgery. And then patients who have either pseudoprogression or real progression on their scans that put into question the resectability of the patient, then I do think restaging is valuable. And by restaging, I'm talking about invasive mediastinal staging. I'm not talking about redoing PETs and CTs, which is obviously standard of care. Sorry. So in terms of some of the considerations when you're trying to select the induction regimen for your patient, I think, and this I presented this a couple of years ago at the World Lung. It hasn't really changed that much for me. So performance status at presentation is critical. You need a patient who's physiologically fit for an operation. As I mentioned before, you need disease that is operable and resectable with a high probability of achieving R0 prior to the initiation of induction therapy. Some of the key considerations prior to surgery as well. So this is sort of a repeat of some of the imaging things that we do. I think a case in some circumstances really helps illustrate some of the challenges we face. This was a patient I saw just 2-3 years ago, fit 68-year-old gentleman. It's 4.5 centimeter mass on PET with an SUV of 15. There's no distant mets. There's an MRI of the brain that's negative, an EBUS that does not show any N2 disease. The 4L was non-diagnostic, was also negative on PET. There's an 11L that shows adenocarcinoma. And this is the CT. Sorry, the quality is not great, but here's a contrast infused CT, and you can see the tumor encasing the pulmonary artery. Even in the most capable hands, this is, if you're going to operate on this patient, it's an intrapericardial pneumectomy. You may want to have the pump in the room. And, you know, this is what myself as a surgeon lives for, is these complicated cases. So obviously we're excited to think about doing an operation like that. We continue to work them up by doing VQ scans, because I think it's hard to avoid doing a pneumectomy in a patient like this. And again, we reassess these issues. And what are the therapeutic options? Well, you know, I think before the Pacific protocol came along, I probably would have keenly advocated for surgery and being a part of this patient's treatment plan. But the results, and this is coming from a surgeon of the Pacific, it made me think twice about taking patients like this for complex, very high morbidity, high mortality risk surgery. But that's not to say that it would be wrong to do, and I still don't think we have a clear answer for a patient with a complex disease like this. I think what I can say for sure is he's not a great case to put into a clinical trial because of the unpredictability of the response and how it could further complexify the perioperative care, at least a clinical trial that involves surgery in the neoadjuvant design. Now, with that said, I really think that the neoadjuvant therapy platform is a strategic opportunity for the patient. All along the trajectory of that patient's care, there are opportunities to positively impact their outcome. I think that when we think neoadjuvant, we screen patients early, we have an opportunity to identify risk factors for poor prognosis and impact them and modify them. This means potentially assigning the optimal systemic therapy. It also means taking a closer look than we normally do for early stage patients at what the molecular profile is and whether the available systemic therapies are suitable. It involves addressing their physiological state and thinking of the operation as something to train for and to prepare for, and not to rush to. They have more time with neoadjuvant therapy to be optimally prepared for a complex operation. So we have very intimately worked with our prehabilitation team to focus well, we do it for most of our patients, but we find the greatest benefit for the patients undergoing neoadjuvant therapy. They seem to go through the perioperative therapy more smoothly, the systemic therapy that is, and we also find that their operations they recover better from them. Dr. Cascone talked very nicely about the concept of immunization of the patient by virtue of neoadjuvant immunotherapy. I think this is another critical opportunity. I think patients need to have this explained to them somewhat, even though it's still to some degree yet to be really clearly shown. I think there's enough data to say that there is a very clear rationale about this concept. I think the scientific opportunities are massive. We've already covered that a lot. And the biomarkers after resection are, now we have abundant tumor post first-line treatment. We can understand whether there are optimal second-line treatments that should be looked at, if there's poor response, and we can make really good decisions about how to assign adjuvant therapy based on the degree of response. So overall, I think, and this is how I approach patients with the opportunity to participate in these trials. They worry, it's going to delay the initiation of my treatment by having to do all these extra tests and perhaps rebiopsying. I try to explain to them that strategically it's smart for them to think about these opportunities. And whether the treatment is given before or after, I think it's been well demonstrated that it doesn't really, at least with conventional chemo, it doesn't have an impact on overall survival. But what I'll draw your attention to is this, you have to look at the whole trajectory of the patient. And there really is almost, well, more than the doubling of grade 3 adverse events when systemic therapy is, conventional systemic therapy is given after surgery rather than before. And Dr. Cascone explained that well. I think surgeons need to be aware of that because what we should be striving for is an optimal total trajectory of care, not just what the small portion that we may contribute to as specialists in our individual areas. I commented on prehabilitation. I'll say it again. I think it's a matter of time. You know, that there are good randomized trials in the lung space that show that you can effectively improve the physiological fitness of a patient, even with just a 2-week intervention. Now imagine they're on systemic therapy for 3 months. Well, I think that what can be achieved is even greater. I show the diagram on the right because it's from our own prehabilitation team in the area of upper GI, and out of this cohort where there was random assignment to prehabilitation or not, more than 3/4 of the patients did receive neoadjuvant therapy because that's part of a very common approach at our center for locally advanced esophageal cancer. And you can see what we were able to achieve both at the preoperative time point, but also in the post-op setting. We have patients who remain above their baseline as compared to when they presented to the prehab program. And I think this is really transformative and is why we're working so closely with these teams. I'll go briefly over this, but I think, as I mentioned again, explaining the notion of tumor immunization to the patients is important. We still have to really prove this, what needs to be done to demonstrate that there's sustained immune memory after these treatments. What is the added value to the adjuvant immunotherapy component? All that are questions that have to be addressed. But it is, at least from a theoretical standpoint, a valuable addition to the approach. So you asked me to talk today because I'm a surgeon, and so let's talk about surgery a little bit. As I mentioned before, I think surgery in locally advanced lung cancer is complex, whether you do it up front, after chemo RT, after SBRT because of a salvage intervention, and post-IO, mono, combo, you name it, it's complicated. There's a lot of talk about in our world as thoracic surgeons about conversions after induction therapy with immunotherapy. I think it's frankly too early to tell. The randomized trials will give us the answer about this, but I don't worry about it too much. Even our best quality data, randomized controlled data comparing open to minimally invasive pulmonary resection, the differences are modest. A lot of people are selling them as major differences, but we're talking about maybe a 5 to 10% difference in minor complications, no difference in major complications, and a change in 1 day of length of stay, and no difference in mortality. So if you need to, I don't know if there are any thoracic surgeons in the audience, so that if you're a thoracic surgeon looking to operate on one of these patients and you feel that it's the safest for you to do this open, do it open. There should be no shame in that. And the goal is to get the patient through the operation safely, and the access is not the most critical part of their care. I'll go through a few cases because I find sometimes they really illustrate the experience of the patient and in some cases the experience of the surgeon in the most clear way. This was actually the first patient we enrolled in Checkmate 816. It was assigned to PD-1 CTLA-4 treatment. There's a big mass in the right upper lobe, and didn't get smaller. I was a little bit disappointed. The thing actually looked like it got a little bit bigger. And if you pay attention there, you can see a little branch of the truncus anterior sneaking into the tumor with a lot of spreading of the mass along the pulmonary artery. This was not an easy operation. It was one that I did open, but we managed to get it out with negative margins and with not much of a treatment response. And I must say I was a little bit dubious about continuing, but we went on and we treated more patients. Because now he's 3.5 years out and doing very well, alive and no disease. So something went well in his care. I showed this patient because I think that it's important not to forget that chemo on its own can have some pretty impressive effects, and our understanding of why some patients may respond super well to conventional chemotherapy or not is not very good. But here's a patient who had the superior segmental right lower lobe mass and a massive hilar 11R lymph node that was so large it was obstructing the takeoff of the right upper lobe. She got gem-cis 3 cycles, and the mass shrunk quite a bit, and the right upper lobe came right back up. The node just melted away. She did super well, and at resection, she had YPT1A and 0 with only 10 to 20% viable cells. So I think that also from a pharmacoeconomic standpoint, it's important to understand when we can achieve really good results with conventional, inexpensive agents. And I think some work has to continue in that vein to allow us to perhaps be more economical with our approach. Unfortunately, this patient about a year later, I'll say our margins were negative. We were really quite happy, but a year later, she came back with this, and this was her progression a year later, and we had to take her back, and through sternotomy, did a cranial pneumonectomy, again negative margins, and there was a PT2AN1 squamous cell carcinoma, and she's still alive now. 2.5 years after pneumonectomy, doing well. But you wonder sometimes, would an IO-containing regimen have provided more tumor kill? Would this recurrence have been averted if there was a T-cell clonotype there that was providing surveillance? I don't know. I wonder about that. So these are some of the questions I think, again, our phase 3s are going to resolve. When we talk about how immunotherapy can make a difficult operation more complex. Here's another patient treated with CTLA-4 PD-1, and you can see it's a central mass in the left upper lobe. And after the second dose of nivolumab, that's what his lung looked like. And you can see a posterior branch of the pulmonary artery going deep into that mess of inflammatory tissue. It wasn't an easy operation. Again, we had to do left upper lobe with a patch angioplasty, but he had a major pathological response, and this was done after 1 month steroid taper. About 2-3 months, I've learned enormously in this period. I saw him in his post-op maybe 3-4 months later. I told him that he had a major pathological response. I felt that he should be really happy about that, but he kept coming to his follow-up visits looking depressed, and I couldn't figure out why he was so miserable. And we did TSH, and even after those 2 doses, he was profoundly hypothyroid. And these were things I wasn't accustomed to dealing with as a surgeon. And so his mood improved after we corrected his hypothyroid state. Now, here's another patient with this right lower lobe mass. She got combination PD-1 CTLA-4, had a great response, but this was one of my more well, I'm embarrassed to say, but you know, as a surgeon, we accept complications that are going to happen. I approached this patient by a minimally invasive technique. The lower lobectomy is going smoothly, and at the time of the we were dividing the fissure between the upper and the lower lobes, and it was very stuck. There was a hilar node there that must have been positive. That was extremely stuck, and in attempting to do that, we injured the right upper lobe bronchus. So I had to convert, we had to redo, we had to reconstruct the upper lobe bronchus and complete the lower lobe. She's done surprisingly well, but did end up having an adrenal metastasis, which we resected, and this was despite a PCR. So patient had a full course of ipi-nivo, PCR, but still develops adrenal metastasis 2 years later. It's resected. She has no evidence of disease now and is on pembro. We'll see how she does. But anyways, these now we were talking about the complexities of the pathological assessment. This patient I like to present because she highlights so many of the difficult issues we face. This patient had 3A disease with the mass that you see in the right lower lobe that was the presumed primary disease, and she had a level 7 that was positive at EBUS. She was on Keynote 671, which is a blinded trial of chemo to chemo pembro in a peri-adjuvant design. She also had this ground glass opacity that you see in the center panel that was PET negative. Now, I might have been stretching the indications a little bit, but it was PET negative. We didn't feel the need to biopsy it. Our radiologist said it could be a scar. She had a lot of emphysema, but in deep down, you know, we had a suspicion that this could be a separate primary. She received her induction course, which she tolerated very well, except for some hypothyroidism. And so we had some suspicions as to which arm of the trial she was assigned to. You can see significant reduction in the size of that right lower lobe tumor. And now we deal with some of the frustrations of trials. This trial and most of pretty well all of the neoadjuvant trials mandate a lobectomy. This big lesion was neatly placed in the superior segment, could definitely have received a segmentectomy. That's not really the standard of care for stage 3A disease, but with the emphysema that she has, you know, as a surgeon, I would have preferred to do a segmentectomy, especially when I found out what we saw post-op. So this is the resection specimen. You see a lot of normal lung and this little white spot at the very top of the superior segment. That is a complete pathologic response. There is no measurable tumor. The nodes had no disease. So this patient has lost close to 20% lung function for what ends up being a little nugget of granuloma. And we wedged out so this is the path. And then we wedge out the middle lobe lesion because we could palpate it and it looked a little bit worrisome. And that is a acinar adenocarcinoma PT1A and 0. How do we stage this patient? And in fact, in the consensus report from the ISLC, this specific circumstance is noted as indeterminate. How do we stage this patient? Is she a PCR? She has some disease that responded perfectly and another lesion that had almost no response. So clearly there's so much to learn here, and these situations are going to be hard to really tease out from the large phase 3 trials because There won't be too many of these cases, but they will be there, and there's so much we could learn from them. But with the trial designs, it's hard to dig deeper. I thought maybe it would be good to just show a quick video of what it's like to operate on these patients. Again, I'm not sure how many surgeons there are in the room, but here's a patient with relatively bulky stage 3A disease. She was a light smoker. NGS did not show any mutations. That's her PET. And she was another one of those treated with the Ipi-Nivo, and after the second dose came in with severe diarrhea. And so we had to stop her, her treatment after the second dose of nivolumab. She got a steroid taper, her diarrhea improved, and she made it to surgery. Now, as you remember from the scan, the subcarinal nodes were not were not involved by EBUS or by PET. And you can see the dissection is easy. This lymph node peels off very easily. So a standard dissection there. I'll just skip forward. This was made for surgeons to go through all the different steps. Now we're looking at the anterior hialum. So this is dissecting the pulmonary vein, and it's really stuck. This is not an easy operation. I worked through a biportal approach. So here we're taking the upper lobe vein. It's going okay. I'll just skip ahead. Now going into the supracarnal dissection in the level 4 space. There was no way for me to complete this without taking the azygous vein. This is not really a morbid thing to do, but it definitely gives a lot more access. And so by doing so, we were able to address that area. When I normally do an upper lobectomy, I would get directly onto the pulmonary artery and take the truncus. But here it was too stuck. I couldn't see planes clearly. It was felt a little bit dangerous, but we kept persisting. And this is the reason why a lot of people will convert, because they'll encounter this kind of anatomy, and you're just a few bad moves away from an imminently life-threatening scenario. So there should be no shame to opening. We happened to soldier on, and it went okay. But again, difficult nodal dissection. And this is only after 2 doses of immunotherapy. So these treatments are potent. So ultimately we were able to get around we're taking the truncus anterior. It doesn't have that nice white plane around it that we like to see. It's very injected, it's stuck. But eventually we're able to complete the operation. So she's done well, and despite all this disease, there's a few adhesions to the pleura. We did some extrapleural dissection there, and eventually got the thing out. Completed nodal dissection. The rest of the case was standard. And this is her path. So it's fibroelastotic scar. All the nodes are negative. I wish we could have known that beforehand, because we put her through a tough operation. Fortunately, she was out of the hospital in 3 days, and she's done well. The real problem with her is not her from a cancer standpoint, but now she's 2 years out and still dealing with immune-related adverse events. She has pericarditis. She's gone on and off steroids. We're looking at other biologics to help treat her pericarditis. And so the long-standing adverse events of some of these more rare immune adverse events are really important to keep in mind in the background, because I think the sort of more mature phase 3 data will give us a better idea of that. Oh, sorry. Now, a lot like Dr. Tascone, I work with scientists. We're interested in the biology of this disease. And so we try and see the neoadjuvant window as an opportunity to really understand resistance to therapy. This is another patient who's on the trial, and it's really just to show you some of the work that we're doing, where we're focusing on multiplex imaging. This is imaging mass cytometry, which is a great technology. And from a single FFPE section, you can stain as many as 40 epitopes, thanks to the power of rare metal antibodies and bound antibodies and the narrow spectral width of mass cytometry. So we were able to get geographic information. My PhD student put this together elegantly. You know, when we look at conventional histology, it's sort of like looking at tiny little pieces of the puzzle, but with mass cytometry, where we can overlay so many different markers at once, it really starts to paint a much more clear picture of what might be going on. The challenge is the bioinformatic analysis. So in this patient, who also was a stage 3A, received Ipi-Nivo, we're able to look at different regions of interest. We can delineate live tumor versus dead tumor. And I'll say I look at dead tumor as a little bit with a bit of a critical eye, because just 6 or 7 months ago, we resected a patient who had chemoradiation for a pancreas tumor. And we did a resection, and we have a program where we're doing patient-derived xenografts and organoids after induction therapy. And so we had taken a chunk of that lesion and sent it to our lab to put in mouse. And the path report came back happily as a PCR. We were really thrilled. But a couple months later, the tumor is growing quite vigorously in the mouse. And so there's another level of complexity in the neoadjuvant trials, where we are interested in the science, where small portions of tumor are being taken to do analytics, and then the pathologist is not always getting the complete lesion. Even if it is a small portion, it can bias or falsify what might be interpreted as a complete response. So, and again, you know, when we say that there are no viable cells, how do we know that? The cells are sitting in paraffin. Are we really certain that there isn't some viability there? It really is an important question for us to continue to address. So just to show you quickly the power of this technology, we can overlay numerous epitopes with very high specificity. And the nice thing is that this is all zeros and ones. It's not a photograph where segmentation can be very challenging from a bioinformatics standpoint. And so we're able to design pipelines that allow us to segment these cells very nicely and do all sorts of analyses for co-expression of these molecules. We can do near neighbor analysis and address various areas of the tumor, the normal tumor, the interface, the normal lung, sorry, not the normal tumor, the interface and the normal lung. And we can do that in the lymph nodes as well. So it's an exciting technology that we're trying to apply as much as we can in the neoadjuvant space. Almost done here. So I think, again, Dr. Cascone touched on the fact that we've only really been talking about immunotherapy, but the space is becoming so much more complex. And this is the proposal for the LCMC4, the next iteration of that group's trials, to bring targeted therapy to the curable space, operable space. And we have, just in the last 4 or 5 months, so many new agents that are coming online that are approved in stage 4 that are certainly going to be of interest for our early stage patients. And we've been embracing this, of course, doing this a little bit off protocol. And in some ways, the COVID pandemic created a situation that was ripe for applying some of these strategies. This is a patient, 62-year-old non-smoker, who presented to me back in March. This was her lesion, which was abutting the SVC. Brain MRI and staging didn't show any distant disease. She had a hilar node that was hot on PET, but we didn't reach by EBUS, so I clinically staged as T3N1. And we were having issues with access to the OR at that time, and we thought, well, why don't we put her on alectinib? And she did have some response to just after only a month of alectinib. We prehabbed her in the meantime through a remote support program for exercise and psychological support and nutrition. And at resection, she had a very standard Bat's lobe. We were able to peel the thing off the SVC without too much trouble. She went home day 2, and there's only 15% residual viable tumor by our pathologist assessment. What would this look like if we had been able to give her 2 months of treatment? I don't know, but I would love to find out. So that's one happy case. But this is a not so happy case. This is a 56-year-old lady, also a non-smoker. I was very suspicious that she may have a driver mutation. Clinically staged as clinical T1N1. And she had an NGS from the EBUS sample that was negative for any actionable mutations. Now, we had to get a core biopsy of the lesion to enroll her on our trial. But because the material is precious and has to be sent for third-party testing, we didn't redo the NGS on the, and for cost reasons, obviously, we didn't redo the NGS from the core biopsy of the lung. So based on the NGS from the EBUS being negative, we said, okay, well, she's eligible, let's put her on the trial. She was enrolled on an IO trial, received anti-PD-L1 and anti-STAT3. And she's one of the few patients I've had who progressed on treatment and was resected YPT3N2 and called M1A because of visceral pleural spread. This allowed her to, the M1A was a little bit of maybe it could have been called intrapulmonary metastasis and just been left at T3, but at least this way, by our standards, we were able to put her directly on TKI based on the metastatic designation because she was found to be EGFR mutant exon 19 on the surgical path. So while conceptually a trial like this is very exciting, putting it into application where doing NGS for early stage patients or even getting biopsies for early stage patients isn't necessarily standard all over the world. So, and the sensitivities of our molecular techniques are not 100%. That said, I really do think that what we're doing here with the neoadjuvant platform is flipping the model on its head. We're not waiting necessarily 5 years to find out who's going to do well. We have an ability to address this in a much more rapid fashion. And, I think that the idea of finding patients who have a reasonable survival ahead of them, doing as much as we can to profile them, understand their tumors optimally, try to predict what the best first line of therapy is, deliver that. And obviously our goal is for long-term survivorship. But by doing this in patients who have a not insignificant recurrence rate, but also a reasonable prognosis, we can sort of achieve this circular pattern of readdressing recurrence and informing future care. And so what I find most exciting about what we're doing is that we're really maximally actioning the windows of opportunity that are offered by this design. Again, as Dr. Cascon talked about, we're looking at all these different correlatives, molecular residual disease, microbiomics, single cell, TCR-seq, immunoprofiling, trying to use these pieces of information to inform care. And what's exciting about it is I think it's generating new ideas that aren't just relevant to the patients who are being treated, but will have high impact for metastatic patients and might also be a pathway to non-operative, non-ablative strategies for patients in whom we can confidently state have had a complete response. So the future is bright and exciting. And anyways, that's all I have to say today. I hope you guys enjoyed it and looking forward to the discussion.
Okay. First of all, let me thank all the speakers for these very informative and exciting talks. So we move to the discussion. I have not received only one question, and I invite all the attendees to send additional question for the speakers.
One question for Tina. Thank you very much for all the speakers, very fantastic talks. But Tina, you have previously reported flare reactions with ayo and ayo, only ayo. Do you have any more experience with a combination chemotherapy and ayo in the CR in the STAR trial?
Yes, that's a great question. So I put out there, Mariano, a slide with the amended schema of the new STAR based on, of course, the results of the Nadine trial you all led, and Atezo chemo, the chemo now being reported, the SAC 1614. So definitely that provided the landscape for that amendment. We're still analyzing the data. We have also, based on the 9LA, incorporated the dual immune checkpoint inhibition with the chemotherapy. And I think that's a very important point based on what Dr. Spicer just walked us through. There has to be definitely some mechanisms that we might be missing in terms of selecting the patients that might be the most candidate to potentially give us an NPR or a PCR with chemoimmunotherapy, whether this is single agent or dual immune. Okay. Personally, at this point, with what we know right now, I am a big supporter of potentially combining the immune checkpoint inhibitor with chemotherapy. I think from what Dr. Spicer mentioned, in some cohorts, toxicities might be definitely something that is not negative. I think tumor size might matter a lot. If you think about trials without immunotherapy, they all tend to select the early stage population. If you think about trials that incorporate chemotherapy, they all tend to go much higher on the 3A. And so that's something that scientifically is going to be very impactful on the type of responses you're going to have, because the tumor burden is going to matter based on what has been published by John Wary and so many other investigators in melanomas or other cancer. It boosts your PD-1 related immune response. So I personally, to answer your question, Mariano, think that the combination of immunotherapy with chemotherapy is going to be something that deserves to be investigated, or what agents, we're still learning about it. I also wanted to mention another important thing that Dr. Spicer touched on. You saw his case from the 816 with the combination PD-1, CTLA-4, no radiographical responses, difficult resection, major responses after combination, doublet chemotherapy. We know from the metastatic setting as being reported by an European and by an American group that responses to chemotherapy after failure to immunotherapy are higher. If you look at the responses to Taxotere after failure first-line immunotherapy, instead of your regular 10% in retrospective studies have been reported 25, 30% in the second-line setting. So this is something that we have also seen in the new STAR. We have absolutely a very similar case of nivo-ipi, toxicity, grade 3 after one cycle, not restaging, not evaluable, platinum-based chemotherapy, incredible responses, NPR as surgery. That counts as a non-NPR on the trial because not resected on trial, but then it counts, right, if you look at the resected population of trial as someone who has still made it to surgery, benefited from the combination of chemoimmunotherapy with the presence of NIF. So again, nodal immune flare in this case is something that can really mislead us. And as Dr. Spicer mentioned, please consider to not only restage with imaging, but biopsy your patients do not take potentially curative surgery away from this patient. So a lot of learning, a lot of experience, a lot of things really being streamlined. But I think, Mariano, the combination of immunotherapy, what type of immunotherapy is still to be determined, plus chemotherapy, perhaps might be an important strategy here.
Let me remember and congratulate Mariano, because today the Nadim trial has been published online in Lancet Oncology. That has been a very interesting milestone for the Spanish lung cancer group. So let me remember also that the MPR is more than 70% in using chemo plus immunotherapy in the neoadjuvant setting.
Congratulations, that's amazing. I've been looking forward to reading this paper for a long time.
Congratulations, congratulations.
Thank you very much.
So
if I can make one comment before I let you go, Muradi, I think we all here on this call are big supporters of, you know, neoadjuvant perioperative trial. We all know what does it take from a medical oncology standpoint, from a pulmonology standpoint, from a surgical standpoint. It really takes a village and really a change in the culture in how you approach the resectable patient. Again, from the staging, the systemic treatment, the surgery. So we want to really, you know, salute you for this incredible team effort that perhaps might be changing the landscape moving forward. So congratulations.
Thank you.
We come back to the discussion. We have a question for Dr. Fernandez Vila. That is, what about the IBUS TBNA transvascular for the staging? What is your opinion? What are the risks?
A mí me parece que bueno, es una pregunta muy específica, en muy pocos centros, los casos son reportados por pocos grupos. Tienes que estar seguro de que entras absolutamente perpendicular, no tangencial, y eso los que han hecho ecobroncoscopia alguna vez saben que no se puede garantizar en la mayoría de las ocasiones. Son casos muy seleccionados y yo lo dejaría ahí. Casos muy seleccionados y nosotros hemos reportado y publicado una disección de una pulmonar, de una arteria pulmonar, tras una punción accidental pinchando una 4L. Y no es tan difícil hacerlo. Probablemente si hiciéramos un TAC a todos los pacientes después de una ecobroncoscopia, nos asustaríamos a veces de las lesiones contenidas que quedan en el mediastino. Lo que pasa en el mediastino es una estructura que muchas veces un pequeño hematoma ahí no da ninguna repercusión clínica. Yo creo que debe restringirse a grupos, a casos muy determinados donde otra técnica sea imposible.
Yo tenía otra pregunta y es en relación, yo creo que la presentación ha sido totalmente didáctica y muy exhaustiva en cuanto a la necesidad de ser absolutamente rigurosos en la estadificación. Pero si nos movemos a un escenario de neoadyuvancia y todos los pacientes o la mayoría de pacientes van a ir a un tratamiento preoperatorio, entonces esta exhaustividad puede verse, diríamos, perder su importancia, perder su relevancia. Do you need I try to translate the question, Tina?
Yes, please.
The question is about if we are moving to a different scenario with the majority, theoretically, the majority of patients could receive neoadjuvant therapy, then the exhaustivity of the staging could be not so important that is considered today. That is a provocative question, but I think I am sure that Dr. Fernandez Vila will answer that.
Voy a seguir siendo también muy didáctico. Yo creo que todo lo que he dicho vale para pacientes que no han recibido tratamiento. En una neoadyuvancia, el EBUS puede ser y debe seguir siendo la primera técnica, pero si es negativo, insisto que es probable que según los resultados haya que valorar otras técnicas. Lo que he dicho de que el EBUS negativo en un centro que tiene experiencia y un valor predictivo negativo solo vale para pacientes no tratados. Otra cosa es que la neoadyuvancia que una micrometástasis no vaya a cambiar los resultados posteriores. Eso es otra cosa, pero la evidencia que yo conozco, y eso hay muchas más, los ponentes tienen mayor experiencia y conocimiento que yo en este momento, en principio la evidencia que hay es esa. Un paciente tratado, el EBUS no es una prueba con ese valor predictivo. Nadie puede asegurar un valor predictivo por encima del 70 en los pacientes tratados. Cambia todo, puedes tener más necrosis, más tejido inflamatorio y entonces en ese caso si compensa hay que hacer una estadificación quirúrgica. Otra cosa es que no compense y eso dejo a los otros ponentes o a los moderadores que lo digáis para el público.
Mariano, ¿quería decir algo o contestar?
No, yo quería hacerle una... I have a question for John, because I have to go because I have another meeting in another place. The question is, what about the role of the surgery in cases with complete response? Maybe in future we can identify patients with incomplete response, maybe with ctDNA or maybe radiomics, maybe other things. What about the role of the surgeon in these patients? What do you think?
I'm probably one of the few surgeons who's really excited about that concept because I'm very lucky in my job here. You know, we have plenty of work, and I actually really think that this would be transformative. There's nothing that as a thoracic surgeon, you have to accept that not too many people feel better after you're done treating them. But most people have loss of lung function, cope with pain. Even when we do the most minimally invasive approaches, there are consequences, there are risks. The notion that we may be soon, thanks to your work in large part, on the verge of designing trials of observation after systemic therapy versus salvage is to me very exciting, and I look forward to designing those trials. You know, on our end, we're pushing, and I am sure my colleague surgeons are going to be upset, but I'm pushing this into earlier stages. We have a protocol looking specifically in node-negative patients. At comparing immunotherapeutic strategies, specifically aimed, and the question is not which is the best regimen, because I don't have the money yet to make that big of a trial, but is to specifically understand what correlates, ctDNA, radiomics, etc., are required to predict with because we need a high degree of certainty, but with as high a degree of certainty as possible, the occurrence of a PCR, and I think with rates in the high 70s or perhaps higher, it goes without question that is the next step. That happened with chemorads when PCR wasn't even close to that much, you know, and so I think it's exciting. I think it's what we need to be moving towards.
I want to make a comment, Mariano and John. I think this is a critical question, and that's what we always, you know, patients sometimes tell us, well, if I had a major response, even, you know, radiographically, do I even need surgery, right? And that doesn't happen very often, especially with, you know, immunotherapy. Actually, sometimes we are really, again, misguided or misleaded by looking at the radiographic responses. So I'm a big supporter of what John just mentioned, you know, being transformative and moving towards the, you know, using the ctDNA or radiomics to actually, you know, maybe spare, you know, surgery and, you know, still give the benefit of greater responses. But I want to also be, you know, just for the sake of the discussion, it's so, it's going to be so incredibly informative to get that tumor bed with no tumor. So to really validate, right, what is happening in that resected specimen with no whatsoever tumor cells, what are the correlations and what's the relationship with the ctDNA. So before you get to the point where you can transform the landscape, you definitely need to have solid evidence that that regression bed, that tumor bed with no tumor cells really is mirrored but what you see systemically by, you know, ctDNA, or what you see at the PET by Radiomics or micro CT and so forth. So definitely we need to get there. We don't want Dr. Spicer and other surgeons to be off job and off duties, but definitely we have a long road in terms of validating scientifically if this is something that can be implemented.
I agree with you, Tina. I think we have a lot of work ahead of us, and we will be. What I love most about surgery, obviously, I think we cure a lot of patients, but it really is a platform for discovery, as you said, and I think there's so much to learn. And we're not done operating on people, but I think there's that little glimmer of hope that it might be in the cards in the future, and how to get there safely is really the question.
And Dr. Spicer, I mentioned to you many times, we know you're ready to take the boards of medical oncology. So if you lose that job, we're more than happy, Mariano and I, to get you on the medical oncology side. We know you will do great.
I appreciate it. There's some frustrated surgeons out there, but I'm a frustrated medical oncologist.
There is another question coming from the audience, is in case of patient receive neoadjuvant therapy and the response is the opposite, is not a pathological or major or pathological complete response, it's no response from the pathological point of view, but in the pathological analysis, there is room for adjuvant treatment. Maybe we need to answer two different possibilities. If the patient receives chemoimmuno, in the end neoadjuvant, probably there are no other different chances for the postoperative treatment, but in case of receive only immuno or immuno, then probably, as mentioned Dr. Gascone, the postoperative, the adjuvant chemotherapy could be advised. Any comment about that?
Yeah, this is a very important question, and I'm actually very happy that it was raised, because this is something that we face every day in our practice. I personally get consulted all the time about, okay, the patient received, let's take the scenario, patient received neoadjuvant chemotherapy and was resected and had 80% viable tumor. Patient has received 3-4 cycles. No, you do not need to give additional chemotherapy after the response. You're given the backbone, 3-4 cycles of cytotoxic chemotherapy. That's the advantage of having a resected specimen. There is no benefit in giving additional potential toxicity. So that's one point. You observe if patient needs port, you disposition the patient to port. There is no need to give additional 3-4 cycles of chemotherapy if you haven't even eradicated anything in the resected specimen. If the patient has received immunotherapy in the neoadjuvant setting, that is a completely ballgame, as you just summarized, because that's the standard of care to completely, administer platinum-based chemotherapy in the adjuvant setting. Whether or not that should be administered with continuation of immunotherapy, that's a very important point. What do I think? Absolutely. I think that perhaps there is still a role in continuing adjuvant immunotherapy with the addition of platinum chemotherapy. For what I just summarized when I answered to Mariano, there is a benefit, in the immune microenvironment in combining those two, especially after you failed the immunotherapy. The patient scenario, chemoimmunotherapy in the neoadjuvant setting, no response. I think that there's still, in my opinion, no value in continuing chemotherapy. There is still value, perhaps, in continuing immunotherapy, whether that should be done in combination with other therapies after surgery or alone, that remains to be determined. And that's why the phase 3 trial with the 1 year of adjuvant therapy, immunotherapy alone, post 4 cycles, 3-4 cycles based on the trial of platinum neoadjuvant will give us that answer for sure.
I actually, Dr. Casson, I want to follow up on that, because it is one of my pet peeves with putting patients on trials, the peri-adjuvant design. I'm not sure, especially after, I suspect after I read Dr. Provencio's paper here, I'm not sure that I'll have equipoise to to advise this full year of immunotherapy, and say in a patient who's had a PCR or NPR? What are your thoughts on that? Do you think that it's...
Yeah, I think, so I can share this data has been presented at ASCO last year with immunotherapy, of course, to a different magnitude, a different extent, single agent combination therapy. If you do a deep immune profiling, and we're learning this also from single cell RNA sequencing, you see immunological memory being established. And that's something that is going to matter in the long run. So if you didn't have, a major pathologic response, I think the perioperative concept is going to be important in that setting. You are probably not going to be enough. It's not going to be enough just to have the year of immunotherapy if you haven't achieved, any major pathological response or any, extensive pathological regression. But I do think scientifically, translationally, is going to be perhaps important to, trigger the immune response with that year of postoperative immunotherapy. And again, in the prospective setting, these trials will tell us in the patients who did not achieve NPR, or they had, more than 50% viable tumor, what does that do? What the mileage that you gain by giving that, year of immunotherapy? And I think it's going to be patient dependent in terms of, biology and other features. So I'm so looking forward to see that data.
Let me come back to Alberto. En relación al decálogo que nos has planteado, los 10 mandamientos, realmente me parecen espléndidos, después hablará Mariano, pero realmente hay una cuestión que no está en el decálogo, que es el tiempo. Es decir, el tiempo en el cual debería realizarse una óptima estadificación con todos los requisitos que tú has planteado, para que esto no comprometiera los resultados, porque evidentemente cuando encadenamos una prueba tras otra, tú has hecho énfasis en esto, pero va pasando el tiempo y los pacientes al final pueden llegar, en la práctica clínica, en el mundo real, llegar a la cirugía con más retraso del debido. Esto yo no conozco muchos datos concretos, pero realmente esto además ahora ha vuelto a ponerse sobre la mesa a raíz del impacto de la pandemia y el retraso en los tratamientos quirúrgicos provocados. Hay una publicación del Annals of Oncology, un modelo teórico de este año, en el cual plantea que evidentemente a mayor estadio, mayor impacto deletéreo de retraso. Si querías ponerle un límite, es decir, en el cual un límite temporal para cumplir los 10 mandamientos.
Si uno no es pecador y cumple los mandamientos, el tiempo está asegurado, porque hay una gestora de casos, hay en tiempo y forma un PET, hay un patólogo, un oncólogo, un neumólogo dedicado, ¿no? Y esto es lo que demuestra la auditoría. Como os fijáis, si cumples, cuantos más ítems cumples de esos 10 mandamientos, la auditoría británica demuestra que los tratas más rápido y viven más, que hasta ahora eso no estaba demostrado. Que una buena gestión de una vía rápida, de un diagnóstico adecuado con los medios adecuados, implica y aporta la supervivencia. Y son miles, 33.000 pacientes encuestados de 129 centros. O sea que el decálogo va dirigido a que si eres un buen cristiano y cumples todos los mandamientos, lo haces más rápido y tus pacientes se van a beneficiar.
Pero tendríamos un tiempo máximo en el cual caer en el pecado. El tiempo
máximo es 4 semanas para los procedimientos iniciales hasta la decisión de un tratamiento y otras 4 como máximo es lo razonable y donde están los márgenes de equivalencia. Probablemente un estadio 3 habría que acortarlo lo máximo posible, pero cuanto más localmente avanzado, peor. Piensa que en los estudios los pacientes que se diagnostican más rápido son los estadios 4, porque siempre tienes más tumor para diagnosticar. Es lo más fácil, no hay que hacer estudios de estadificación. Y sin embargo es paradójicamente donde aportamos menos terapéuticamente, ¿no?
Está también, si quieres preguntar algo, Alberto.
No, yo levantaba la mano Gemma, no sé si quería hacer alguna pregunta.
No, Alberto Cruz, ¿no?
Sí, Alberto Cruz. Sí. Yo me estaba refiriendo a Alberto Cruz.
Pero sí, que no lo veo. No, yo no
no,
lo veo.
Por supuesto que tú si querías decir algo lo dirías.
Alberto no lo
Está Alberto mirándonos, pero no. No sé. Dale más volumen. Ah, espera.
Tiene el micro.
Ahora, no. Ahora, Alberto Cruz, cuando quieras.
Hola. Bueno, pues aprovecho un poco a dar la enhorabuena a organizadores y participantes por el alto nivel. Y bueno, retomo un poco el inglés para... I have a question for Tina, because you mentioned that maybe different histologies, we have to set a different threshold for major pathological response. What do you think also on specific mutation? Maybe a major pathological response with a, I don't know, point mutation, EGFR or whatever, have a different prognosis or not?
Yes, thank you, Alberto, for this question. This is very impactful, especially these days. And Dr. Spicer did touch upon this. I did, in the end of my talk, mention that, yes, histology, I'm truly convinced that might matter in some setting. The data that I show is from the Sloan Kettering group. There might be perhaps different cutoff, 10% versus 65% in terms of how much tumor regression can be correlated with long-term survival. Because remember, you're not going to do anything in terms of advance in the field if you have an NPR that doesn't really correlate with your long-term survival benefit. PCR, same thing. So that's one point as far as histology. I know that from all the trials we're doing, we're learning so much about how the histology is impactful. We just published a CCR a couple of months ago with the neoadjuvant chemotherapy plus anti-angiogenic therapy. And as part of the review process, we were asked, does histology matter? So when we did the retrospective analysis, really, we didn't see any major differences in responses, NPR versus no-NPR in adeno versus squamous. That's a limited number of patients. But again, the phase trial will be very important in answer to that question. It is possible. Remember, squamous has a different landscape on neoantigen. It's a completely different causation, right, with smoking and so forth. So that's something that is going to matter in terms of impacting responses to immunotherapy. Whether that's just radiographically, pathologically, is yet to be determined. As far as the oncogenic drivers, that is a critical. Retrospective analysis that did take a look at responses in patients with EGFR mutation, sensitizing mutation. I'm not talking about the atypical mutation, the non-canonical. I'm talking about your EGFR exon 19 deletion, your EGFR exon 21 substitution. These patients whose tumors harbor this mutation tend not to respond to immunotherapy in the metastatic setting. There is a CCR elegant paper from Gaynor and his group in really a team effort looking at a number of patients with EGFR and ALK mutation treated with immunotherapy. Responses are in the order of 2–3%. That's dismal. So that's important to know that you should not treat. Dr. Spicer mentioned a very elegant example of someone who perhaps not known to be EGFR exon 19 deletion, in the initial staging for resectability and so forth. Disposition to immunotherapy, no response, relapses, and so forth. So the oncogenic drivers are going to be critical. As right now, outside of trials, the molecular landscape does not dictate your therapy. But Dr. Spicer mentioned to you, we show you that umbrella, that's the premise trial with the LCMC3, where basically the goal is to disposition every patient whose tumors is known to have a mutation to a specific bucket where you have an inhibitor specific for that trial. If you think about the ADORA data, you just cannot neglect that no matter what your eligibility criteria are on the trial, you should, and that's what I do in my practice, and I fight this with insurance all the time, and I do not care. The patients, even if you are in the early stage setting, in 2020, with what we know, they got to be profiled. Because if you look retrospectively, what we have learned, what Dr. Spicer just mentioned to you, or preliminary, you know, information that we're learning by looking at LCMC3, looking at New Start. The vast majority of the patients who had a progression on chemotherapy, on immunotherapy on trial, are most likely to have an EGFR mutation or you know, an ALK fusion. Perhaps that's not the case for the BRAF V600E are coming out as potential drivers that might still be sensitive to immunotherapy, and that's perhaps based on the tumor mutation burden. And I'll stop there because this is sensitive data, but that is going to be published soon. So a lot of learning, and that's very relevant. But if I can, you know, summarize what Dr. Spicer mentioned, what we've learned, profile your perioperative patients. Do anything you can to assess resectability and oncogenic driver. And if you have an EGFR mutation, do not disposition that patient to, with what we know today. Okay, when we started New Star, when we started LCMC3, when we started 816, we did not know about this data. But you cannot neglect the ADAURA, and you should disposition that patient to surgery or standard of care neoadjuvant chemotherapy, and then Tagrisso, 3 years adjuvant. That's all you should do. I hope that answers your two questions.
Yeah.
Well, one of the most important things that we did as an institution, and it's not standardized through our province yet, is to have reflex NGS for any biopsy. There's a small needle biopsy. So if it's an EBUS or a TTNA, it goes directly to NGS. Prior to that, you know, it had to be clinician driven, so we had to request it, and that would have made it, if we were still in that mode, it would be impossible for us to recruit properly onto these trials. I think the importance of this cannot be understated. And it's tough. It's really difficult. Like I mean, in Canada, it's not, things aren't as quick as in MD Anderson, but I have a patient who's fully eligible for Keynote 671, who's a non-smoking Japanese man. And I'm waiting for the NGS, and he wants to start treatment, and it's a tough position to keep the patient in for a week or two, depending on the turnaround time for your NGS. But I think it comes back to approaching the patient and explaining this is a strategic time in your care, and the more we approach this first line of treatment with in an informed way, the better your long-term outcome will be. I was scarred by that patient that exploded on immunotherapy, and you know is resected and metastatic, and I don't know that much would have been that different had I just operated on her up front in the end, but the adverse events of the sequencing of these treatments, I think, is also an important consideration.
And also, if I can add one more relevant thing to this point, you know, educate your patient about this is not a waste of time. This is really a strategy to give you the best outcome. And if you end up having an EGFR mutation, remember that your EGFR mutant patient respond to chemotherapy, platinum-based chemotherapy, better than your wild type. I mean, in the frontline setting, your responses are in the order of 40–45% as compared to 25%. So that's something that you really are not losing on if you wait for that profiling. And I agree with John. I don't think doesn't matter where you are. It takes time to get a thorough molecular profiling. Sometimes we try to just get an EGFR PCR, you know, an ALK fish to just get some information.